speaker to mute. Yeah. So, good evening, everyone. Myself, Dr. Prashant Gowda, Secretary, NNF Chapter, Karnataka. It's my privilege and pleasure to invite for today's session. We have got two most important sessions as a neonatologist. One is about the antenatal steroids, and the second one is the chronic lung disease, that is BPD, bronchopulmonary dysplasia. And today we have got two wonderful speakers. So the first talk will be by you, sir, Arvind, sir. You would like to go first?
Yes, please.
Okay, sir. Yeah. So first, our beloved and most respected, and he is called the Saraswati Putra of neonatology. We would like to give a warm welcome on behalf of NNF Karnataka, sir.
Thank you, sir. Thank you. Thank you so much.
And I request Dr. Guru Prasad, sir, to introduce the speaker. And I request to start the session following that. Over to you, Guru Prasad, sir.
Good evening, Prashant, Dr. Dinakar, entire team NNF, and we welcome Dr. ARVIND SHENOY and Dr. Keerthi for this evening meet. At the outset, I should congratulate Dr. Prashant Gowda and Dr. Dinakar, the team NNF, especially both of you, for doing a wonderful work for the state chapter of NNF. I'm seeing this for nearly 2 months plus. The type of topics that you have chosen and the galaxy of the speakers that you have really invited, it is phenomenal. It is not an easy job to conduct so many webinars with really people who are very well versed and practicing these aspects of neonatal medicine. And the last 1 week is very pleasurable because you have covered various aspects of neonatal pulmonology, starting from basics of ventilation, the graphics, and then the non-invasive ventilation, then invasive, and then high frequency ventilation. And 2 days before, Dr. Leslie just concluded with I know. So now today there are another two topics. As you rightly said, antenatal corticosteroids in enhancing the lung maturity, the pros and cons. And the other one is bronchopulmonary dysplasia. I heard that Dr. Arvind is presenting. I'm extremely happy. It is always nice to be talking about Arvind SHENOY. He is not only your guru, he is guru of most of the neonatologists in the state, in the country. He's one of the senior most learned neonatologists and a great teacher. He's of our generation. We used to call him Sachin Tendulkar of neonatal team at that time. He has got wonderful way of presentation and taking home very clear messages at the end of the presentation. See, having really ventilated babies, Dr. ARVIND SHENOY is one of the few neonatologists in the country who worked with very immature babies, very ELBW babies in 90s. So they were the first one to start up ventilation and surfactant and subsequently salvaging these small babies. And over decades, they have salvaged so many babies. And with time, I think Dr. Arvind and Dr. Karthik and their team are facing this new problem of bronchopulmonary dysplasia like in the Western world. So to talk on this topic, I think Dr. ARVIND SHENOY is the right speaker. Now, ARVIND SHENOY doesn't need any introduction. He's a senior consultant neonatologist at Cloud9 Hospital and a good friend of most of the senior members of NNF Karnataka State Chapter. Without wasting much time, now I request Dr. ARVIND SHENOY to really take the crowd with the participants with you and give a very clear, I know once you hear to his presentation, you will have no doubts, but still there will be a lot of queries because there are a lot of fellows and residents. We request them to post questions in the box so that we can take up at the end of both the speakers completing their presentation. Over to Dr. ARVIND SHENOY.
Namaste. Thank you, Guru. I'm just your Shishya. With that, I must outside thank Dr. Kotturesha, Dr. Kishore, Dinkar, and Dynamic Prashant for having invited me to share my thoughts on this topic. And the reason I took up this topic was actually nothing to do with BPD. When Prashant called me, I was reading about a cytokine storm, which is going around the country in a disease many of you related to a virus. And I thought when I was reading up about that, I might as well talk about the cytokine storm which occurs in newborn babies, which causes BPD or chronic lung disease. And when I was preparing the talk, Dr. Dinkar was kind enough to phone me and say, ಸರ್ ಮಾಲಿಕ್ಯುಲರ್ ಲೆವೆಲ್ ಮೇಲೆ ಹೆಚ್ಚಿಗೆ ಮಾತಾಡಬೇಡಿ, ಜನ ಎಲ್ಲ ನಿದ್ದೆ ಹೊಡೆದು ಬಿಡ್ತಾರೆ ಅಂತ. So in due deference to him, there will be only a passing reference to cytokines, but there is a lot of literature to suggest that what actually happens in BPD is the lung goes on fire, an inflammatory fire, and this is akin to so many diseases which we know around us, including the most famous one which is affecting our country right now. With that introduction, let's address the learning objectives. We'll talk a bit about pathophysiology of BPD. We'll talk about certain definitions of BPD. We'll talk about treatment. And actually, this is what I told Keerthi. This is why I want to talk first. I'm going to bash postnatal steroids, but it should not be so much that you stop using antenatal steroids. So do listen to Keerthi after this so that you know where to use steroids. And we'll talk about a little bit about preventive strategies and new treatments which are on the horizon. The best way, I think, is to take a case. And this is right way back in the 90s, as Guru was saying. Let's take a 32-week male neonate was born by emergency cesarean at a peripheral hospital and developed respiratory distress and grunting soon after birth, and was managed with IV fluids, antibiotics, and headbox oxygen. The baby progressively worsened and at 28 hours was transported to the referral unit with severe distress, not maintaining saturation in 100% oxygen. So this baby was at admission. This is the X-ray at admission. And I'm sure many of you, without blinking an eyelid, will say this is the ground glass appearance of HMD. This baby was quite sick. It had all the lines, and many of you must be seeing these kind of cases even now. Though I think in a 32-weeker, you shouldn't really be having this bad distress, but probably during that time, Keerthi had not yet given his talk, and this baby did not have the benefit of having antenatal steroids. This is what happened to the baby. And unfortunately, if this was an interactive audience, I would have said, what's your diagnosis? But many of you can actually make out that this baby blew a pneumothorax, and you can see the chest tube in situ. So this was somewhere around 3 days after admission. And then it developed this. And as you can see, there are cystic changes occurring on the right side. And though there is hyperinflation, which I think is because we were using a lot of PEEP those days, and the child was really not much better. And this was by about day 15. And this is what happened when the baby was 3 weeks old. So this is a baby, 32 weeks. And the X-ray, we had series of X-rays till about 8 weeks. This was the picture. This baby was requiring 30 to 40% oxygen, was not had failed extubation at least twice, still was on the ventilator, and there was no sort of retrieval in sight. This was a baby who was very sick at admission and not much better, I would say, 8 weeks down the track. So this, my friends, was the BPD we were seeing then, and some of us will be still seeing these kind of BPDs. I'm sure, I don't know whether we can poll the audience, but it is a problem, I think, which still we haven't driven out of our country. Come back into the 2010s, 2013 to be precise, 25-week-old, 800-gram male neonate born after full course of antenatal steroids, emergency cesarean, delivery room CPAP, transport on CPAP to NICU, LISA done. Sorry, we used to do Insure. It's not LISA actually. Actually, Insure we did in those days. Managed with CPAP, NIMV, then back to CPAP for 3 weeks, developed nosocomial pneumonia at 3 weeks, intubated and ventilated for 4 days, CPAP for another 2 weeks, multiple attempts of CPAP over the next 2 weeks, high flow nasal cannula for 4 weeks, and at 36 weeks, this was the X-ray, was on HSNC, 6 liters per minute, and 25% oxygen. Now, this is a baby, you would still agree, fits into a definition of BPD. So we are now in our country seeing both the BPDs. That what we saw earlier was probably the first case was what was called the classic BPD. Here we are now seeing as smaller babies survive what is called as the new BPD, and is no longer all that new even in our country. The other is a different kind of BPD that some of us see, full-term 3 kilo neonate, cesarean for meconium strain liquor, found to have distress and grunting soon after birth, transported from a Mufusal hospital by local car, arrived gasping, intubated at arrival, ventilated with conventional, then HFOV. Of course, they had not listened to Dinkar's lectures in those days. Developed bilateral pneumothorax, required bilateral chest tube placement, developed sepsis, pulmonary hemorrhage. All of these were managed, not as well as the speakers who have spoken earlier, but anyway, to the best of our abilities. And this was the X-ray when the baby was roughly around a month old. So again, this baby is having chest X-ray, and the pneumothoraxes have not yet revived. The baby is still intubated and is still requiring oxygen. So here is a baby who has term and has had significant lung injury because of so many events and is really not in a good shape. I know the chest tube is too far in on one side, but barring that, the rest of the lung is also in a pretty bad shape. 3 failed extubations, FI to 30 to 40, SIMV pressures of 20 on 5, tidal volume of 5 ml per kilo. We are not making any headway. So BPD still exists. So let us go back into history and see what we can learn. First described in 1967. So BPD is now more than 50 years old, and by Northway. And he described preterm infants, usually mechanically ventilated, had radiological changes, and had oxygen requirement at 28 days. This is just like the first case we were discussing, and this is old BPD. So the diagnostic criteria of BPD changed over a period of time. And this was in 2010 when they had an NIH conference in America. And then they came out with certain criteria. And they clearly divided it according to 32 weeks as the trade-off. If the baby was less than 32 weeks, this is a little busy slide, you assess the baby at 36 weeks post-menstrual age or discharge. And if the baby was breathing room air at 36 weeks, it was mild BPD. If it required less than 30% oxygen at 36 weeks, it was moderate BPD. And if it required more than 30% oxygen or required any kind of positive pressure ventilation or CPAP, whichever at 36 weeks PMA, this baby had BPD. For babies born at or beyond 32 weeks, the cutoff was slightly changed. The assessment was done at 56, which means if you add 8 weeks to 32 weeks, it was done at term at the EDD. And the criteria remained the same, that if the baby was breathing room air or less than 30% or greater than or equal to 30% with positive pressure, this was mild, moderate, and severe BPD. So it looked as though that they had come to a very good standard definition for BPD. But did everyone agree? The answer is no. Why didn't they agree? Because at this time, by the time it became popular, the use of heated, humidified, high-flow nasal cannula had come into practice. And they were not part of this classification. If the baby is on HFNC, how do you classify? Do you still use 30%, less than 30%? Because HFNC, by definition, gives some pressure, but is really not it's a flow-driven device and not a pressure device. So it does not answer this question. Then there were a small subgroup of patients, which some of us would have also seen, where the baby doesn't have much respiratory illness, comes off oxygen, and then gradually worsens over a period of time, which when we were doing DM, we used to talk about something called as Wilson-McKitty syndrome. These did not obviously fit into this classification by the NIH. And what people did was Poindexter et al. Looked at it. They said that there are other problems. There are comorbidities like sepsis, pulmonary hypertension, PDA, and the definition does not take this into cognizance. And also, it became clear by that time that BPD is not only a disease of lung parenchyma. There is a component of reactive airways. Many of the BPDs have a wheeze. Many of us will agree. There's also a component of trachea or bronchomalacia with or without reflux. And third is there is a component of pulmonary vascular disease, or to put it succinctly, pulmonary hypertension. So the suggestion was given that if the baby requires more than 21% oxygen or requires more than 4 liters per minute flow on the triple H FNC, then you'll classify this as mild BPD. However, if the FiO2 was greater, then we follow the same classification as was used earlier by the NIH conference, that 30% cutoff as the marker between moderate and severe BPD. Then came what is called as physiological definition of BPD. Michelle Walsh then said, what you need to look at is physiology and not actually go by pressure or flow. And she suggested what is called as a room air challenge test for 30 minutes. She said, if the babies had positive pressure support or were requiring more than 30% oxygen and maintaining a SpO2 between 90 to 96, this is BPD. So these are not candidates for the room air challenge test. You do the room air challenge test for the remaining, that is those who are not requiring more than 30% and who are not on positive pressure support, that is babies who are on HFNC or on low flow. And these you put into room air for 30 minutes and see if there's SpO2 saturations fall below 90% during this 30 minutes. If the saturation falls below 90%, then this is BPD. If it does not, then this is no BPD. Why she probably did that was there were probably a large number of babies who are on small fractions of oxygen, less than 30%, who the doctors in the US were scared of taking off. And she suggested this room air challenge. And what it did was the reclassifications reduced the number of babies who are said to have BPD by about 10%. So this became the physiological definition of BPD. I think quite useful in our setup also, because we don't have unlimited beds. And if you want to send a baby home and you think it has BPD and it's requiring minimal flow, minimal oxygen, it's worth getting this room air challenge done. So what is BPD and what is the current understanding? Now, this is a very comprehensive and a busy slide. So I want to take you stage by stage and also give you some of the rationale why they had the 32 weeks cutoff. What is clear from BPD, understanding of BPD, is that BPD has an antenatal phase. The antenatal exposure of steroids and much more important choriamnitis acts as an insult. Choriamnitis insults the lung, and so also, and this was news to me, IUGR. If you have a baby who has got IUGR, this baby's placenta produces certain growth inhibitory factors which affect the growth and differentiation of the lung. I didn't know this. This is in some research studies, and it's basically been proven in animal models. They have not proven it in human models, but there seems no reason to doubt it, because as studies have shown that IUGR babies with prematurity have a greater incidence of BPD than plain AGA babies. Second thing which has come out is there is a genetic susceptibility. And I'm actually very fortunate, because 3 of the people who worked with us in PGI, and Guru probably knows all of them, are actually in the forefront of research for BPD. Ambalwanan, whose article I will be quoting many times along, was with us at PGI at the same time. And he is considered one of the leading lights in BPD research, especially he's a professor of cell pathology and neonatology at Alabama. Vineet Bhandari has been working a lot, and you probably have heard him at the NeoCon, which was held in Bangalore last year. Works on the genetics and the microRNA in BPD. And the other person who has done a lot of work on choriamnitis is known as Amcho Soraisham. And if you Google him, you'll find that he's done a lot of work on choriamnitis and BPD. I actually wrote to Ambal to give me some lead articles, and I'm thankful to him to have, helped me understand this disease a little better. So what they say is that premature delivery, which occurs between 23 to 32 weeks, at that time, the lung is in this the canalicular stage is ending and the saccular stage has progressed, and the alveolar stage starts at 32 weeks. And this is why the definition of BPD is divided into less than 32 and 32 weeks and above. So when there is a premature delivery in 23 to 32 weeks, what these exposures do is developmental arrest or delay, as you can see on the lower part here. And this is what causes the new BPD. Now, after 32 weeks, after the saccular stage, the alveolar stage occurs. And if you have these postnatal exposures, they will add to the lung injury and go towards BPD. I need not dwell much on ventilator-induced lung injury. A lot of wonderful sessions have occurred on NNFK, and please go through them. We all know that oxygen is a poison, and I'm going to stress on this. I think we need to be very careful when we use oxygen in neonates and not just in preterms. I'll talk a bit about infections, and infections are very, very potent cause. I'll talk a lot about steroids, and there is pulmonary fluid overload and nutritional deficits I'll mention in passing. If there is discussion, we'll come to that. And what this does is adds to structural injury. So there is a developmental arrest in the premature, very preemies, and there is a structural injury in old BPD. And there is a bit of overlap in these in-between gestations where you can have a developmental arrest as well as this thing. So what we are talking about is a disease syndrome with multifactorial causes, which we call as BPD. More about this later. The first thing, and this is Amcho's work, and there's a very nice review article I've quoted at the below in the Korean Journal of Pediatrics, where there has been shown clear association between chorioamnitis and BPD. So it does look as though that when there is insult to the fetal membranes, that inflammation also affects the lung and contributes to lung injury even before the baby is born. And which is very interesting that people have studied chorioamnitis in 4 different compartments. Number 1 is only if the placenta is involved. Second is if only the umbilical cord called phenicitis is involved. Only if the amnion and the phenicitis is involved, and everything is involved. High-grade amnitis, which shows involvement of everything, or at least majorly the placenta and the umbilical cord, is definitely associated with BPD, especially in the very, very preterm. Now look at this. This is a little interesting. If you look at it, phenicitis, that is only histological inflammation of the cord without involvement of the amnion or the placenta, actually protects against RDS. So this is very, very interesting. Nobody has explained why this happens, and it's an observational study, and we really don't know much. The second part is, and this will has an implication on treatment, a high rate of presence of ureaplasma urolyticum has been found in those placenta which have chorioamnitis. These are studies done in Korea. And last week in the PAS, there was a presentation from Brazil where 65% of the babies with BPD had ureaplasma isolated from the tracheal aspirate. How common is it in India? I'm not sure. I haven't really found any Indian study. And also it is not that simple. Apparently ureaplasma urolyticum can colonize and not cause infection, or can also colonize and cause infection. So what's the difference? Is just colonization, does it need to be treated, or do you have to actually treat chorioamnitis? The question is open. I don't have the answers. Any role of azithromycin comes as a direct relation to this question. We'll talk about that a little later. So the understanding of BPD was nicely summarized by Christian Spear in his seminal article in 2003. And a lot have changed since then, so I will begin here. What they said was chorioamnitis causes intrauterine cytokine exposure. When you resuscitate inappropriately by giving too much oxygen, too much tidal volume, and or give the baby infection, or the baby gets infected before or after birth, all these contribute to sequential lung injury. The lung injury starts a cytokine cascade called as pulmonary inflammatory response. And along with this response, there is healing which occurs, which results in fibrosis. The cytokines released during the inflammatory as well as the healing part cause inhibition of the alveolarization and vascular development, and a combo of inflammation, healing, alveolarization with abnormal vascular development causes BPD. And this model from 2003 till about 2015 was what we thought we knew about BPD. So we had some people like our Ambal and his group, and this was the Eunice Kennedy Shriver National Institute of Childhood Neonatal Development Network Research Network. And they started studying cytokines, and this is a very busy slide, but stay with me. They studied a huge plethora of cytokines to find out if there is a biomarker they can pick out, because the problem with BPD is very similar to your house catching fire. You will all agree the best time to put out the fire in your house is when it is starting. It's pretty silly that when the house has burned out, then you start running with buckets of water. The same way in BPD, the treatment has to be given early. To define whether this baby will go into BPD or not, we don't have early markers. And they were searching for a marker. Yavadadru one sikkidre, then we can say, this is elevated. That means this will go to BPD. And unfortunately, this did not, this study, which was quite a rigorous study, which used a large number of patients, they took the trouble of taking blood and tracheal aspirate cytomarkers, and they found that there was not a single biomarker. But what they found was interesting. Number one, in classic BPD, right from here to here, all these three rows, they found high levels of interleukin 6, 10, and 8. Okay. Now, this is a little busy. All you need to see is the pyramid and the square. Okay. You look at the pyramid and the square. The pyramids are here. You can see here. Okay. And these they have compared with the centiles or quartiles of normal lung. So there was a slight increase, you can see here as you go along, of MIP alpha, increase in CRP, and a low rate of BDNF, that is brain-derived neurotrophic factor, and RANTES, which is actually a regulated on activation normal T cell expressed and secreted factor. So these two they found were low, and these 6 they found was low. And very, very interesting, GM-CSF levels were low in classic. In atypical BPD, these were high, that is IL-8, and in addition, IL-18 was also high. You can see here, the levels of IL-18 kept climbing in babies who developed BPD as compared to the normals, which stayed actually on the lower side. MMP9 was the other factor, which was common to atypical as well as classic BPD. So the point was a large number of cytokines are elevated, which they narrowed down to about 6 or 7. IL-18 could distinguish between atypical BPD versus classic BPD. Now you may say, what is atypical BPD? Atypical BPD was what I mentioned to you earlier, which you used to call Wilson-McKinney. In those babies, not much lung disease in the initial part of this thing, and slowly the baby starts becoming tachypnic and then goes on to oxygen by the time it reaches a PMA of 36 weeks. So in this atypical BPD, the IL-18 levels were elevated in addition to IL-8 and MMP9. So basically no single biomarker, very interesting, very intriguing. So BPD is a clinical syndrome. The oxygen requirement does not correlate with pathology. The pathology can have impairment of septation, lung fibrosis, atelectasis, vascular problem, vascular remodeling, impaired angiogenesis, airway injury and remodeling, tracheobronchomalacia. The second thing which became clear was that severe BPD is a distinct entity compared to mild or moderate BPD. And Vineet Bhandari and his group did a retrospective review of a series of large number of twins who underwent BPD and showed that there is a definite genetic predisposition. In genetically similar twins, monozygotic twins, the incidence of BPD was comparable, while in dizygotic twins, the incidence of BPD was different. So they said there is a genetic predisposition, and there is no single biomarker, and there were several cellular mediators. So it looks as though that BPD is a chronic lung disease with many factors. So what are these factors? So they looked at various factors in lung tracheal aspirates, blood, and tried to match them with the clinical variables which we know, even looking at exhaled end titles, carbon monoxide, lung functions, some biomarker in the urine, and including CT and MRI of some of the babies who developed severe BPD. What they came about was an even more surprising conclusion. They say that these are all the superficial things, and the actual reason of BPD lies at the molecular levels. And they said the future lies in the omics approach, the genomics, proteomics, metabolomics, and microbiomics. Okay. By now, if most of you haven't fallen asleep, bear with me, because it is interesting to see how at the molecular level things are developing. What does this mean? And this is my understanding of it. I'm not an expert on this. And any questions you have, please address to Dr. Guru Prasad, who will clarify the same. The genomics said that the genome of a baby predisposes to BPD. And how does this happen? That when there is an insult, the certain genes get repressed and some genes get overexpressed. And how do they do it? The transcription process gets altered. And this is called as the transcriptome. And the small mRNA, which Vineet Bhandari talked about last time, the expression of this microRNA changes. So some are overexpressed, some are underexpressed. And when these mRNAs are expressed, the proteins produced in the cell change. And when the proteins are produced in the cell change, the metabolites which are collected around the cell change. When the metabolites change, the development of the alveoli, the development of the vessels, the response to infection, all that changes. And surprise, surprise, and this is what really surprised me. Again, I can't take a poll. Many of you have heard of using probiotics in NEC and others. And in NEC, there is a lot of work and many lectures we have had that there is a microbiome in the gut. And lo and behold, there's a microbiome in the lung also. And that has been shown that when the metabolites change, the microbiome also changes. And when the microbiome also changes, it also influences the metabolomes. So there is a cross flow, and all this influence the BPD. So it looks like BPD is considerably more and more complicated than just it is just talking about oxygen and the lung. So, but I'm sure this is a very complex topic, and if Dinkar and Prashant want this to be dealt on, we should probably call an international speaker to talk about it. But my understanding is that at the cellular level, a lot of things are happening in BPD, and more treatments will probably come in trying to break this vicious cycle which you see here. And this cycle needs to be broken before we can say effectively that we are able to treat or prevent BPD. So the next question is, we are talking about BPD, and this was a question I actually discussed with Dr. Kishore, because it's very difficult to say no to Dinkar. So when he calls saying that you have to talk, you have to talk. It's like your headmaster saying, "Martiyo illu anta." So with due respect to him, I said, yes, I will talk. And I blurted out this chronic lung disease because I was reading it at that time. It's like Freudian slip. So the next question was, is this relevant to our audience? Am I going to be talking to people something which doesn't really interest them? So I tried to look up Indian literature, and it's interesting that, yes, in our country, and this is way far back as in 2002, as you can see from the first, it has been reported from Chandigarh, that 50% of ELBW babies are develop BPD, and 9% of the BLBWs, as defined as oxygen at 28 weeks, develop this thing. And this was before the consensus definition. And subsequently from AIMS, they have not actually given incidence of DASD, but they say that about 25% of extramural admissions based on the database require ventilation, and a proportion of them go on to develop chronic lung disease. And 92% of ELBWs in ELB require some FENOY, and 64% require invasive ventilation. So it seems and it looks that there is definitely BPD in our country, and if it is low, I'm the happiest person about it. So I decided, since we didn't have more data, and actually it is the same, because I strongly urge NNF Karnataka and also NNF Center, we probably should have a BPD database, because we should know, because there are a lot of long-term implications of the illness, which I'll talk about later. But I took this off the, again, the NICHD and NNN data for 9,575 infants between 2003 and 2007. And what they showed was not surprising, that BPD in the 22 weeks gestation was very high, nearly about 56% in this paper, babies were taught to develop BPD. And this BPD was the severe BPD. The pyramids are all the severe BPD. While the incidence came down by 23 weeks, by 24, it was down to less than 40%. And by the time it was about 26 weeks, it was less than 20%. Now, you may wonder why I am talking about 26 weeks. In my informal discussions with other people around the country, it looks as though most of the neonatal units are having reasonable survivals, good survivals beyond 26 weeks. And if you do the numbers here, 20, 20, and maybe about 30, the total, this thing is around 70% of babies born at 26 weeks in our country are likely to develop BPD if they survive. So we are talking about a long load, because this is the area, as neonatology spreads in our country, we are going to find babies with more and more BPD. And currently I'm happy the numbers are small, but I pray that it doesn't rise, because this data from America 13 years ago seems a bit frightening to look at. So is BPD important or relevant to us? Important, I'm not sure, but relevant, yes. It's probably there, and it may grow. Old BPD is also relevant to us, because still babies are being born in mafusal areas. And we, as of now, we have not succeeded in a universal network of transport. We are all doing our little bits, but much more research is required on treatment. We need to focus more on prevention in this area, because the other problem is most of the old BPD research has virtually stopped. The Americans and most of the world is focusing on new BPD in the extremely premature. And I think there is a role for youngsters in the audience to think of old BPD as a potential area for research. The second reason why BPD is important actually came in the IAP Neocon in Hyderabad about 2 years ago, when a lady called as Barbara Schmidt delivered an oration. She talked about the lessons from the CAP study and BPD as a marker for poor neurodevelopmental outcome. And she has actually published this. She talked about a 43% BPD rate in that cohort of CAP study, which, as many of you know, had very, very preterm babies. And what interested me was that if you took these three parameters, BPD, severe brain injury defined as grade 3 or 4 intraventricular hemorrhage, cystic PVL, porencephalic cyst, ventriculomegaly 13%, and severe ROP defined as ROP which required laser or treatment in the form of the VEGF, anti-VEGF. If you took this and put it into this thing, if the baby had none risk factors, the risk of developmental delay was only 11%, and these are the 95% confidence intervals. If the baby had any one, 22.9, it doubled, okay? Any two, it increased by another double, went up to about 44%, and all three, It is 3 times anyone, around 61%. So it looks as though BPD is a marker for poor neurodevelopmental outcome. And that I think was news to me, because I thought it's only the second one which was a marker, and the third one I thought was independent, but it looks as though these 3 are good parameters for this thing. There is a follow-up paper on this by Srinivasamurthy from Hyderabad, where he says we should add a 4th, which is sepsis. If the child develops nosocomial sepsis, then it adds on to this algorithm. But I think we need a much larger scale study to see whether that holds good. This came from Dr. Alan Jobe's article. What he showed was even more elegant. If you follow here, that if the baby has BPD, depending on where you took this thing, it was associated with serious respiratory morbidity. That means if the baby had oxygen requirement at 40 weeks, serious respiratory morbidity, and so on. So, look at the other side. And if you look at it from the neurosensory impairment does not shadow the respiratory impairment. So what it means is that if you continue having BPD even at 44 weeks, your chances of having an abnormal neurosensory impairment is approximately the same if you had it at 34 weeks, but not so the respiratory morbidity. So what it means is, if the baby continues having oxygen requirement well beyond the expected date of delivery, the risk of brain injury doesn't increase, but definitely the risk of having a severe respiratory morbidity is slowly climbing. So longer you keep the baby on oxygen, it looks as though the longer you will have to manage respiratory problems in these babies. How do you diagnose BPD? That is, I think, child's play for this audience. Anybody can diagnose tachypnea, retractions, need for respiratory support, mechanical ventilation, NIMV, CPAP, need for oxygen, HSMC we have already talked of, and the failure of the room air test. Chest X-ray, if it reaches this thing, I'm sure in many of the units in our city itself, even the ward boy will say, sir, adakke lungs sari illa anta. So BPD diagnosis is not really much of a challenge. Presence of interstitial infiltrates, cysts, and areas of hyperinflation are characteristic, and they are the reflection of the pathology. Where there are areas of breakdown, there is cyst. Where there are areas of cytokines, infiltrates, cellular infiltrates, you get interstitial shadowing, and areas of hyperinflation are there where there is destruction of alveolar septum. So this revisits the pathology. I don't think there's much to discuss. What we need to know is the old BPD, which was described by Northway, had 4 stages of stage 1, 2, and 3, 4, where there was a gradual evolution from ground glass appearance to opaque fields to small cysts to hyperinflated neck. And then when you looked at the pathology, there was a close match between pathology and this. For learning purposes, I think this is pretty good. But nowadays, with the advent of surfactant, I think there is a much more change in this, and very scarcely do we find this kind of radiological progression. What paper I found useful and which we use in our unit is actually this paper from Anne Greenhouse unit. And this helps you predict whether this baby will go into BPD or not by day 7. So take a AP chest X-ray in the supine position and look for these. Look for fibrosis, cysts, and expansions. And what do you look here? If you find interstitial shadows, divide the lung into 4 quadrants. And for each quadrant, if you find interstitial shadows, give 1. And for cysts, if it is absent, or if there are small or multiple or large, give 0, 1, and 2. And look at the expansion, 14 ribs, 14 to 16 ribs, or greater than 16 ribs. This particular, this thing I have a little quarrel with, because these days people use a lot of CPAP, and you can actually create a larger score if you inadvertently give larger CPAP. But I think in our unit, we have found in a very useful thing. And I think it is important to know this, because if you are deciding to treat this baby, then you probably should have some sort of score to treat early. As I mentioned earlier, if your house is getting on fire, it's better to put out the fire earlier. So this is a very useful score which we use in our unit. At 7 days, you can do it. And the maximum score is 8. And 0 to 3 is low risk for chronic lung disease. Greater than 4 is high risk for chronic lung disease. So if you have this sort of X-ray, you can easily score it, divide it into 4. You can see that there is infiltrates in all the 4 quadrants. There are some small cystic changes here and here. So you give 1. And if you see that, if you count from above downwards, there are 16 ribs visible in the picture, and your score is 2. The total is 7. And this definitely is a very high risk for going in for BPD. Of course, for seniors in the audience, this is child's play. Many of them will be with closed eyes able to say that the baby is at risk for BPD. This is a very busy slide, and this talks about the treatment of BPD. And I will just run through it because most of you know it, and probably there are other traps. What is interesting is what the CAP study told us. Caffeine definitely, when used for apnea of prematurity, prevents BPD. You all know the dose, 20 per kilo and 5 to 10 maintenance dose, and it should be continued till the discontinuation of respiratory therapy. The CAP study elegantly showed that the fraction which received caffeine versus placebo had considerably less BPD. The second treatment modality is diuretics. Furosemide is used initially. One needs to know that it is best used early in the disease if required. It's a loop diuretic involving BPD. It has a serious side effect when prolonged use of nephrocalcinosis, so it's not recommended on a prolonged basis. We prefer to use hydrochlorothiazide where required, 20 to 40 milligram per kilo per day, and is especially useful if long-term use is required. Needless to say, you need to watch the potassiums, make sure the baby, and sometimes we have used spironolactone in addition to hydrochlorothiazide. Bronchodilators, we are all familiar with salbutamol, and whenever there is significant bronchospasm, I think it should be used. Systemic steroids, I'll come to later. The other treatment which has been shown, albeit in small studies, is to use vitamin A, 5,000 IUs thrice weekly for 4 weeks. Now, this was given IM. We use the same dose orally. I would be interested to know what Guru and other people in the audience are using. And this seems to be a pretty harmless therapy, and we use it in all our ELBWs who are on ventilator. Caffeine, I just want to go into a little more detail because caffeine seems to work on the brain as well as on the lungs and also on the heart. So this is a wonderful slide which came in the European journal. And what it showed was that there's a reduction in ventilatory support and IPPV when you use caffeine, reduces the oxygen treatment in 36 weeks, lowers the rate of BPD I've already mentioned. It improves minute ventilation and tidal volumes, reduces incidence of apnea, reduced extubation failure, improved lung function. And a large number of benefits were seen on the brain. As you know, in the CAP study, at least at 18 months, there was an improvement in some areas, and 5 and 11 years, also some areas of motor function, there was improvement. So last of all, the last Rambana in our armamentarium is steroids. Now, the problem with use of steroids in BPD is, should we use them early or should we use them late? Should we use hydrocortisone? Should we use dexamethasone? Should we use inhaled or should we give it with surfactant? For all these, there are studies, so let's look at them. In fact, there are meta-analysis, and I'll be actually dwelling more on meta-analysis rather than individual studies. And this one came from the Cochrane database, where they looked at systemic postnatal steroids for prevention of BPD. And what we learned was that there are a large number of studies, this is the number of studies, large number of this thing, but see the effect size that there is with both dexamethasone and with hydrocortisone, some effect. But if you see hydrocortisone, the effect size is crossing 1. It's actually at 1. So probably it looks as though dexamethasone is the drug of choice as per this meta-analysis. But if you go on down this thing, survivors discharged home and look at the other parameters. So you will find that dexamethasone and hydrocortisone are roughly similar when it comes to the remaining parameters when used early or late. So it does look as though postnatal steroids do work in bronchopulmonary dystocia, but the matter doesn't end here. When you use it, you must be aware that you're going to have a lot of complications. You must look at the GI bleeding, perforation, and these are from 32 studies, of which 11 used hydrocortisone, varying dosing regimens. Dexamethasone was used in this dosing regimen, and hydrocortisone was used in even more. And you will see that there is a large number of side effects, and I will focus on GI perforation, which was much more. The risk ratio was 2. And what happened was that when you looked at it, even sepsis risk was very high. So when you are using early postnatal systemic steroids, be aware that there is a lot of risk of sepsis. And in our circumstances, this particularly hydrocortisone, and this was actually weighted heavily by the Premiloc trial, which was a French trial, which showed the large amount of late onset sepsis in those babies who had received early hydrocortisone. So what the Cochrane is the benefits of early postnatal steroids may not outweigh real or potential adverse events. It definitely benefits earlier extubation, but there is an increased risk of GI bleeding and perforation. And the long-term risk of abnormal neurology and cerebral palsy is still there. However, no study was sufficiently powered to detect important long-term sensory outcomes. So it appears appropriate to curtail early corticosteroid treatment for prevention of BPD, which means try not to use it. We really don't know what it does, and it definitely can affect the brain. Late steroids. Now let's look at this. Now when you look at this, definitely when you use steroids, you can see that the number 133 per thousand. So the risk comes down when you use steroids, late steroids for chronic lung disease. And definitely the death or BPD comes down, as you can see lower here. But what else? The risk for cerebral palsy climbs. So it looks as though giving late systemic steroids clearly increases the risk of CP. And death or cerebral palsy, they say at the latest reported age, the risk is lower. But this is, I think, trying to hide the fact that cerebral palsy risk is greater if you use steroids. Or to put it in another way, if you don't use steroids, most of the babies will die. If you use steroids, they will survive, but large proportion of them will have CP. So actually, it's like the devil and the deep sea. The late steroids harm. And what harm do they come? You can see here, hyperglycemia, glycosuria, hypertension, hypertrophic cardiomyopathy, severe ROP. And this was a shock to me. You will see that use of late postnatal steroids increases the risk of severe ROP, and this does not cross 1. So which means it's a significant risk. So even though late steroids reduce the risk of death, they risk a large proportion of severe complications. There is a significant short-term, and as I told you earlier, long-term. So the conclusion of the Cochrane review was steroid therapy reduces rate of BPD, facilitates extubation, need for later course of corticosteroids is not changed. They may require corticosteroids again, reduces need for home oxygen, improves survival at 28 days, has increased side effects of hyperglycemia, hypertension, severe ROP, and abnormal neurological findings. And all of these Cochrane reviews end with this sentence: no study was sufficiently powered to detect important long-term sensory outcomes. And you may wonder why this is. Because nobody starts out saying, I'll give dexamethasone to improve the brain function. So you always start out saying, let us reduce the BPD. So what happens is when you reduce BPD and you are in these small babies, some babies die. So the ultimate cohort shrinks, and consequently you can't really have a study large enough to tell you whether dexamethasone really causes a big problem or not. Inhaled steroids, does it make any difference? The answer is it still gives rise to these side effects, as you can see: hyperglycemia, hemorrhage, and gastrointestinal perforation. So there is a significant risk even if you use inhaled steroids as compared to a systemic steroids. No evidence that inhaled steroids confer any advantages of systemic steroids. This may be because, they have given an escape clause because a better delivery system is required. And to resolve this issue, further studies are required. Again, Sachin Shah is one of the authors of this Cochrane review. And using inhaled steroids beyond 7 days, 8 trials, 232 patients. And what I'd like to see you to see is that when they used inhaled steroids beyond 7 days, a significant large number of babies in the study population also got intravenous steroids. So this, even though people are talking that inhaled steroids may be safer, the real thing is that when they used it, many of the physicians in the study group actually gave the baby IV steroids when they found that the baby was not improving. So again, the question is really, inhaled steroids probably don't work, and you'll end up giving them double, inhaled followed by IV steroids. Should we add surfactant to the steroid to the surfactant mixture? These were studies which came from Taiwan, which added 0.25 milligram per kilo of budesonide to Survanta, and small numbers. And what happened was the enrollment was at 60% FiO2, follow-up of 2 years. And at follow-up, you can see not the entire cohort. These are 2 studies, 35 out of 60 and 32 out of 56 were followed up. And even they had a significantly lower physical and motor development index. So even adding surfactant to, adding steroid to the surfactant doesn't seem to help much. And it also has adverse neurodevelopmental outcome. I'm not sure what this is due to. And there had a significantly high impairment rate of 31%, 40%. So very interesting. May decrease lung inflammation, but seems to also affect the brain. Why low PDI and MDI, I can't say. So I think further studies are required before this line of treatment. So friends, the question I'm sure all of you will ask me, you're saying don't use steroids. Do you use? The answer is very rarely, yes, I do use. Okay. And I've just given you the doses people use. The most common dose was used in the Premiloc trial, because that was the one which really showed maximum effect. But remember, this was the trial which showed that the late onset sepsis was high. So if you're planning to use this, be very careful about sepsis. So this is the dose used in the Premiloc, 1 milligram per kilo in 2 divided doses for 7 days, followed by 0.5 milligram per kilo per day for 3 days. So the total dose of 10 days, total cumulative dose was 8.5 milligram per kilo over 10 days. We sometimes use the DART regimen, and this is starts in a de-escalating dose, start at 0.075 milligram per kilo per day, per dose, 12th hourly for 3 days, then 0.05 for 12 hourly for 3 days, 0.025 for 12 hourly for 2 days, and 0.01 12 hourly for 2 days, a total 10-day trial. Total cumulative dose is 0.89. And this we have used in some circumstances when we felt it required. If the baby is stuck on ventilator, we use a slightly larger dose for extubation protocol, 0.25 milligram per kilo, 12 hourly for 3 doses. Now, friends, if you go into literature, there are 100 different other dosage regimens. And provided you read the study and decide which is best suited for you, given the situation, you could use steroids. But the point I'm trying to make is steroids significantly have adverse effects, and try not to use them if possible. What are the other treatments? I will go over these in passing, and because I think I've taken a lot of time. But INO initially was considered promising, as also sildenafil, but has now been shown to be not very helpful. I'll briefly mention about a trial using omega-3 fatty acids, LC-PUFA, DHA actually, supplementation in lactating women. The trial, I think preliminary data was presented last week at the PS conference. And hormonal therapy has been talked about. Nobody has used it. Erythropoietin, very interestingly, has been talked about, but seems to be more effective for the brain rather than for the lungs. Cell therapy, mesenchymal stem cells, very interesting therapy. And interestingly, there's a report for use in our own country by a single unit, which has been used, but again, it is still investigational. Antioxidants mentioned only in animal studies, copper, zinc, superoxide dismutase. Inositol, I will talk about it a little bit. And there is this recombinant human cell club cell 10 kilo Dalton protein, RHCC10 it's called. This was one of the molecules reported by Ambalwanan and his group, where they found that when those babies who did not have or in BPD or had were protected against BPD, the expression of this protein was high. This is from that what is called as the Clara cell, and this is the protein which has been found high in tracheal aspiration in those babies who do not develop. So one of the theories is maybe we should give this. Montelukast has been tried and not found to be of much benefit. And clarithromycin I will talk about. I don't know why this came up, but anyway, I'll talk about in passing. So what are the trials under evaluation? Caffeine is also being tried in a different dose and at an earlier phase soon after birth, and that trial is going on. And furosemide has also been used in a trial is going on early in the evolving BPD. Systemic corticosteroid, numerous trials, various regimens, and in 7 to 14, this thing, as I told you, not recommended. Inhaled corticosteroids, escalating doses people are trying, again not recommended, because as I told you, inhaled steroids actually didn't show any benefit. I talked about this Clara cell protein. Surfactant with combination with budesonide and INO is again one of the trials, not yet out. Inositol has also been tried, is a phase 3 trial, and that is in progress. And mesenchymal, at least 5 ongoing trials on mesenchymal stem cells. This thing, they say 3 have been completed, but I have not seen any published reports as yet, but maybe my literature survey was not adequate. And so these are some of the therapies under evaluation. So steroids, bitter poison, early use has late use may not be safe, still and what we need to do is prevent BPD. So let's talk about prevention. Antenatal steroids, I think Keerthi is going to talk about. I'll talk about the other things. But before we go to that, I would just want to talk about azithromycin, clarithromycin, and erythromycin. See, one of the theories about BPD in those countries where they have a high incidence of ureaplasma infection or colonization, they have shown that there may be some role, especially as I told, clearance of erythromycin in 40 per kilo per dose or azithromycin in 10 per kilo per dose for varying duration, 10 days, 7 days, and so forth. Various trials have been tried. But as per this meta-analysis, it demonstrates that prophylactic therapy was associated with a statistical significant reduction in BPD given from zero, starting from soon after birth. But given the limited information on pharmacokinetics and potential harm, further studies need to be done before routinely using azithromycin in the neonatal population. Why azithromycin? Because it is also shown, as many of you know, to be an anti-inflammatory drug. Okay. One study from Turkey has also used clarithromycin. And again, there is not much benefit shown in some of the studies done in other places. In fact, last week in the PAS, there was a study, RCT from Brazil, where they showed there was not much difference in BPD, though the ureaplasma colonization rate came down when they used azithromycin. So it does look as though using azithromycin may benefit in some areas where there's a lot of ureaplasma, but it may not make a significant difference in other parts. I think still studies would be required to test that out. How to prevent BPD? So antenatal steroids, already Keerthi is going to talk. I'll talk a bit about delivery room CPAP. I think early surfactant has also been spoken, but the basic thing is to prevent lung injury. And I'll talk a word about mom's own milk. Antenatal steroids, Kirti, you will talk about it later. But what was interesting to me was in a meta-analysis which came from Cochrane, antenatal steroids reduce RDS, but did not seem to reduce BPD. I wonder why. So Kirti, that's a question for you. Second, when you give delivery room CPAP or all the trials, various trials, COIN trials, support trials, so many are, what it showed was there is a clear reduction of BPD when you give early CPAP. So the way forward seems to be to give BPD, but retinopathy of prematurity, this confidence intervals don't cross 1, but be careful because there may be a slightly higher incidence, but delivery room CPAP seems to be the way forward. Early surfactant already I've talked about and has already been spoken by other speakers. LISA has a trend towards reduction of BPD, but has failed to reach statistical significance, maybe because of inadequate sample size. What was really interesting, and I'm sure Dr. Asha Benkappa will be happy about this, is that human milk has been shown in various combinations, exclusive versus exclusive formula, partial versus any formula, and human milk versus donor milk versus formula. In all combinations, the diamond favors human milk. Why does human milk cause less incidence of BPD? Very difficult, lot of answers. Is it because human milk contains stem cells? Is it because of human milk oligosaccharides, which changes the microbiome of the lung as well as the gut? These are a lot of questions. We really have no clear answer, but the way forward is very clear. Use human milk, and that reduces the incidence of BPD. Then coming to a trial, I don't have the data from this trial, which was presented, I believe, recently last week at PAS, which was called the Moby Dick trial. This was an interesting trial where they hypothesized that long chain polyunsaturated fatty acids, as many of you know, DHA, has an anti-inflammatory effect. So this trial tried to give DHA to the lactating mothers of extremely preterm babies and see if that reduced the incidence of DHA. As I told you, I'm not aware of whether they did cause, because the outcome for them was BPD-free survival at 36 weeks PMA. I'm sure the initial reports would have come. So I think more on this maybe on the next talk. So this seems to be an interesting way, give the mother the medicine so that the baby improves. Nobody, as far as I know, has given DHA supplement to babies directly, but that also may be something which may be worth studying. So what do we do? How do we manage DHA? So actually nothing new. I'm actually taking you back to the AIMS protocol, and nothing really has changed after all this talk. Use antenatal steroids, avoid bagging, use T-pace resuscitator, use blender aid air oxygen. Sustained inflation is there in their website, but I think it should be removed because of the recent study which showed higher mortality. You need to restrict the fluids, early enteral nutrition, early CPAP, early rescue surfactant. Minimally is invasive surfactant administration. Again, I will not touch on the ventilatory settings. I know there are people in the audience who know more about it than I do. Oxygen saturation targeting, I think, has been talked about in one of the earlier talks. Early extubation. Caffeine I have talked about. Dinkar sir, early rescue high frequency ventilation. He'll talk about that. Fluid increments in small amounts, aggressive parenteral nutrition, vitamin A and permissive hypercapnia, caffeine to facilitate extubation, non-invasive ventilation, and prevention of hospital-acquired bed. Nutrition, fortified breast milk. Again, there are some questions on this, but yes, nutrition is very important, mom's own milk. And as I mentioned to you, last, keep the steroids for the last. Consider nebulized bronchodilators. The only thing is in this AIMS protocol, I quarrel with this. Most of the evidence suggests that maybe you should use, if you want to use steroids, you should use after 7 days, not wait till 10 to 14 days. But again, I may be corrected. The evidence is still not that clear cut. If you want to use steroids, you probably, that's why the lung score by Anne Greenoff we find it very useful. So in case you have a real bad baby, you should use it early rather than late is my personal opinion. Long-term outcomes. So how do babies of BPD do? Compromised pulmonary function, reduced FE1, FEC, catch-up mirrors the length. The pulmonary functions mirror length, not weight in these babies. And the architectural distortion and altered pulmonary function continues up to young adulthood. Jagdish and if they are there on this, the pulmonology people will agree that many of the preemies have hyperactive lung, and maybe Hariram could also comment on that. There is definitely compromised pulmonary defenses, increased susceptibility to infection, increased susceptibility to viral induced lung injury, increased GERD and microaspiration, exercise intolerance, abnormal ventilatory responses, hypoventilation, and even pulmonary hypoventilation, hypertension has been described in this. So what's new? I've talked about biomarkers. I've talked about, I just want to differentiate, add one more point, that most of the studies were on the blood biomarkers. Now cellular biomarkers are coming in. CD4 T cells expressing CD62L receptor, activated eosinophil, bombesin-like peptides, and lesser number of endothelial progenital cells, meaning the endothelial forming cells are lesser in the tracheal aspirate, suggesting that this baby will have impaired angiogenesis, and different types of mesenchymal stem cells. Unfortunately, whether you take the biomarker from the blood or in the trachea, all have a poor predictive accuracy, which basically means we still don't have the correct answer how to predict BPD. What do these suggest? They suggest do a panel of biomarkers. If you really have to do biomarkers, do a whole lot of them. Look for some ones. I had already mentioned once they found significant. And if you want to narrow it down, low GM-CSF, increased IL-8 and increased MMP9 would be the ones to bet on, is what Ambal says. But he knows more about it than I do. Difference in cytokine profiles, I have already told you. They provide an improved estimate of risk of BPD or mortality. Anyway, but they are far from routine practice. The omics of BPD, Vinit talked about this. Downregulation of microRNA, increased level of certain RNA predicts BPD. And now people are talking about abundance of proteobacteria and decreased lactobacillus. They're also saying that if you do the microbe profile in the trachea, it changes as BPD changes. So you probably need to give the probiotics if you are thinking of sequentially. How are you going to give it in the lung? Nobody knows. Proteomics, metabolomics, and what is more interesting is now you'll have something like you do for your car. They are talking about a metabolic nose, where they take some metabolites which are breathed out in the exhaled air, and in the air you analyze them and you have a metabolic nose which tells you, okay, this way we will go for BPD. So it looks like science fiction. But what is very relevant to us is that they are saying that big data, when used along with this, will be able to predict which babies much more accurately. And so now computer science is moving into neonatology in a big way. In conclusion, BPD is a clinical disorder, multifactorial, and is probably a combination of chronic lung disease with overlapping features. A cytokine storm causes the developmental arrest and lung damage. It's a common problem in EL beta population, also in our country, and is seen in severely ill babies who have received prolonged ventilation. The crux, as far as we are concerned, is actually prevention, and this involves all the things you already know about. If BPD develops, one should probably consider steroid with extreme caution. And remember, BPD is a marker for poor neurodevelopmental area. So coming back to where I started, it looks as though some people have realized that COVID-19 also causes a storm like BPD. And I won't be surprised if Dr. Koteresha and Dr. Dinkar and Dr. Prashant are called to manage the next COVID-19 cases, because they know all about BPD. Thank you all for a patient hearing. Back to you, Dr. Guru Prasad and Dr. Prashant.
Sir, Guru Prasad, sir.
This is the Panjang Lake where we are fighting the Chinese.
Oh, okay. Sir, as usual, very excellent. And that is the reason, sir, your Saraswati Putra. Actually, your first son for Saraswati, knowledgeable person. Otherwise, I would have not called you like Saraswati Putra. You are the great person. BPD, really, really difficult subject. Still, if you'll ask me what is the definition, even for me, it is difficult. Okay, but you got, sir, please be prepared. You got around 22 questions. So you should be ready for Viva from 213 people in the Zoom. Today is the last day for the Zoom. Tomorrow onwards, we are doing something else. Okay. And in the even, what is that? Facebook also people are there. From Facebook only, we got lot of questions from the Facebook and as well as this also. Sir, be ready. Dear audience and participants, please. Today is the last day for our Zoom applications. We should do and show the solidarity with our Indian soldiers as well as with India. So somebody has misguided, or really it is true, still I don't know, because they are telling Zoom owner is American. Only some co-CEO is a Chinese, but anyhow, why to be in the trouble? And they told owner is still Chinese. So that is the only reason we are removing Zoom after this last session. Whatever it is, please should not feel bad. I know Microsoft will be little difficult. First, you should download that Microsoft app. Then you should put your email ID. Then ID number we are going to send to you. You have to enter that. That's it. Email ID, ID number. It is very easy, but it will ask many questions. So don't lose the patience. So please, dear friends, that is one thing. Second thing, what is it? Next topic is beautiful topic. It is laryngeal disorders. None other than a great speaker. Everybody knows. Who is he? He is working in Manipal Hospital, ENT surgeon. Okay, number one. Number second is he has already given 2-3 lectures, and we got really impressed on his lecture, because once we were there in the Japan, that time we heard about CPAP talk. I think so. Arvind Shenoi sir was there. I think so. In that, somebody has showed laryngeal stridor, how it looks, what is the grades, then tracheal, this thing also, tracheomalacia or bronchiomalacia or unilateral bronchiomalacia, some compression, how it looks, how they will do the anterior sling preparation to the even aorta, they will do the suture. So none other than E.V. Raman sir is going to talk on Saturday, starts at 5 o'clock. So he is the only speaker. He's going to talk about 2 hours. He will give all the videos, because I have seen in my life, first time in Japan, later I saw we are also doing. It is there in the Manipal Hospital with E.V. Raman, and he is a kind-hearted person. If the patient is not having money, he is having charitable things. He is trying to help. So now the second thing, Dr. Prashant.
Yes, sir.
Yeah, you want to talk, you want to talk something regarding our app, why we are changing?
Yes, sir. Yes, sir. Yes, sir. I mean, it is very clear that we have to stand by our soldiers and the country. So whatever best we can offer to them, we are offering. So after today's meet, we are planning not only the application of Zoom or anything related to China as well. So there is nothing called, it is just showing our support to all the people who are there, who are fighting for us. Following this, we please, as I said, please download Microsoft Teams. So we have purchased Microsoft Teams, irrespective of, even though we have purchased Zoom for a year, we are letting go our Zoom money, and then we are switching to Microsoft Teams, which we have bought new. We will be sending the link and meeting code. We are trying to create one right now, but it is taking little time for us. Now it's going to take more than a half an hour to set up things. But however, like how we have sent the Zoom link to all of you, we will be sending the same Microsoft Team link to all of you. As rightly said by Dinakar sir, It is like opening up of Gmail account. When you first download the Microsoft Team, you have to put your credentials, and then once it is on, it is very easy. Then just you have to click on the link or copy paste the link what we have sent, the number, and join meeting. It is very easy. So once you have downloaded and updated.
Dr. Prashant, can we request speaker as well as all the audience, at least wherever they are sitting, at least for 15 seconds, let we all pray for their souls, please, sir. Thank you, sir, everybody, because from NNF Karnataka chapter, and not only NNF, from all our hearts, we are praying for India and for the brave souls. So the next speaker from all the messages is from NNF Karnataka President, Vice President Dr. Kishore Kumar, President from Kotresh, and all the joint secretaries, starts from Dr. Sidhu Charki, Dr. Kumar, Dr. Raghavendra, Dr. Suhail Ambi, Dr. Leslie Lewis, and all the EB members, as well as all the subcommittee members, as well as all the NNFK members, our gratitude, our really condolence and pray for their souls. Please, over to Dr. Keerthi. Please, sir, over to you.
Yeah, Dr. Guruprasad sir, we will take up the question once the session is done. So, and I would request you to share your experience as well along with while moderating the session. So, over to Dr. Keerthi. He is the chief neonatologist at Mandya Medical College, and he has been doing a great service in Mandya and trying to handle kids who requires not only the medical attention, even the financial aspects as well. And you are doing a great service to our society and a great job being in Mandya district. Thank you very much for accepting our request. And I request you to start the session. Over to you, Dr. Keerthi.
Thank you, Dr. Prashant. First and foremost, I would like to congratulate and thank Dr. ARVIND Shenoi sir for such an excellent talk. It was as such indeed, like Guruprasad sir said, like it was a star batsman performing at the top end like Sachin Tendulkar. So congratulations once again, sir. And before I start my topic for today's discussion, the outset I would like to thank wholeheartedly the NNF Karnataka chapter for giving me this opportunity to be a part of this today's webinar. Thank you, Dinakar sir, thank you, Kishore sir, and thank you, Dr. Prashant. Coming to my today's topic, antenatal corticosteroid therapy. So till now, the discussion had been like, don't use. So let's rescue the audience like being by favoring the use of steroid. Outline of my presentation to start off with the introduction and what are the clinical benefits of antenatal corticosteroids. How does these steroids act? Which corticosteroid to choose? In what dose? What is the ideal interval and timing? What is the role of repeat dose or rescue dose? And role of steroid in different gestational age groups and specific populations. Coming to introduction. Preterm birth is the leading cause of neonatal mortality and morbidity. In India, going by the numbers, like there are almost like 26 million live births annually, of which there are 3.5 million babies who are born preterm, and of which within there are 3 lakh babies who are dying due to premature related complications. Overall, India alone almost contributes to 25% of the global preterm related deaths. To morbidity, the various morbidities, the respiratory morbidity, to be precise, RDS, which forms the primary cause of early neonatal mortality and morbidity. With this burden of preterm related morbidity and mortality, what are the measures we can have basically to reduce this preterm burden? So either we got to prevent preterm birth, or when the preterm birth is imminent, it's inevitable, maybe we can try out some of the measures to improve the neonatal outcomes, which includes the antenatal corticosteroids, the use of magnesium sulfate in the antenatal period, and subsequently in the NICU, better ventilation strategies, use of surfactant, use of TPN, and encouraging use of KMC. So I'll restrict my today's discussion to antenatal corticosteroid therapy. So how did it all start, in fact? So way back in 1960s, Liggins and his team, basically, they could demonstrate in the animal models that steroid, when administered, was accelerating the fetal lung maturation. And in the meantime, evidence was available too, with autopsies done on infants who had died within 3 days after delivery because of RDS, showed that the adrenal size too was almost less by 19% in case of babies who had died because of RDS. And it was also supported by evidence saying that there is a correlation between the cortisol levels and the fetal lung maturity. All this evidence, in fact, prompted Liggins and his team to start the human trials way back in 1968. It was the first trial, in fact, and studies from then on and subsequent studies for all these decades have demonstrated a reduction in the neonatal mortality and morbidity in preterms in a consistent manner. What does the Cochrane review say? Cochrane review 2017 says that with respect to primary outcome in the form of mortality, the neonatal deaths are reduced by almost 31%. With respect to morbidity, RDS being reduced by 34%, and IVH by 45%, NEC by 55%, and NICU admissions by almost 20%, and early systemic infections by 50%. This is with respect to primary outcomes and the short-term outcomes. What about the secondary outcomes? With respect to mean birth weight, both the groups, the steroided and the non-steroided groups, had a similar mean birth weight. But with respect to chronic lung disease, the impact was inconclusive. As Sir was highlighting in his talk, yes, it was inconclusive, though it was able to reduce significantly the incidence of RDS. It happened so, though basically steroid group had less need of respiratory support, oxygen supplementation, and surfactant. In spite of this, the chronic lung disease load, basically they were not able to conclude on that. With respect to long-term data, so what does the review say? The long-term follow-up data into the childhood showed that there are lesser risk of development delay at the age of 3 years, but had similar results with respect to steroided and non-steroided group with respect to childhood weight, height, head circumference, blood pressure, lung function in the form of FEV1 or vital capacity, hearing impairment, and behavioral or learning difficulties. So that's about the beneficial effects with respect to mortality and morbidity. What about the safety profile of using these antenatal corticosteroids with respect to mother and the fetus? With respect to maternal safety, it was clearly demonstrated even in the Cochrane review that there is no increased rate or risk of maternal death or chorioamnitis or endometritis. In fact, with minimum mineralocorticoid activity, it is known to be safe in severe preeclampsia. There is a small increased risk of GDM and the transient rise in the leukocyte count, which settled by maybe around 4 days after administration of steroid. With respect to fetal safety, there were some transient changes in the form of like decrease in the variability of FHR, the low biophysical profile score with respect to fetal breathing movements and body movements. But these again were transient phenomenon which basically settled down within maybe 4 to 5 days after completing the steroid course. And even there was noted transient improvement in the umbilical artery interstitial flow, but it didn't last for more than 3 days. So overall, with this safety profile of antenatal corticosteroids and a significant beneficial effect with respect to prematurity related mortality and morbidity, this antenatal corticosteroid therapy, a low cost, a low technology intervention, has become a standard part of clinical practice. ACOG Committee 2017 recommends a single course of steroid should be offered to all between 24 to 33 weeks, 6 days, when there is a risk of imminent preterm delivery in the next 7 days. What is the mechanism of action? How does it act? Physiologically, we all know that there is an endogenous surge in the corticosteroid concentration in the late gestational period, which is known to accelerate the maturation of organs. So this administration of exogenous synthetic steroid, the principle behind this is to just mimic this endogenous surge when the preterm birth is imminent and the pregnancy can't be continued till into the late gestational period when the physiological surge is known to happen. So when the exogenous synthetic steroids could be dexamethasone or betamethasone when administered during pregnancy, the enzyme which is there in the placenta, 11-beta hydroxysteroid dehydrogenase, is not basically going to degrade this betamethasone or dexamethasone, so it can readily cross the placenta in its active form. So this enzyme, speculate about this enzyme we need to know here is basically in the placenta, the same enzyme has got a beneficial effect, whereas the same enzyme which has been found to be there in a fetal brain or in the neonatal brain in good concentration compared to an adult brain can land up harming the brain when basically the betamethasone concentration is high in the blood, can easily be transmitted across the blood-brain barrier into the brain so as to induce the neuronal injury. So it's something like a double-edged weapon. So once into the fetus circulation, it has got pulmonary effects and extrapulmonary effects. What are these pulmonary effects? Those things can be subdivided into two categories. One is cytostructural maturation and the inducing effects on the various cells and receptors. With respect to cytostructural maturation, it is known to accelerate development of type 1 and type 2 pneumocytes, increase the saccular and alveolar gas volume, decrease the alveolar septation. With respect to inducing or the stimulant effects, could be on type 2 pneumocytes to increase surfactant production. It stimulates beta receptors to release surfactant and absorb alveolar fluid, stimulates antioxidant enzymes, which are basically protective from the oxygen free radicals in the immediate postnatal life for lung protection. And it is known to increase the gene expression for the epithelial sodium channel, which is important for fluid absorption. Clinical point to note here is whatever the architectural changes that are induced by this steroid in the fetal lung are irreversible. I mean to say it remains static even though the steroid effect is weaned off. Whereas the inducing effect or the stimulant effect basically on the various cells and receptors is reversible, is dose dependent. I mean to say with the weaning of steroid dose or the steroid effect, this inducing effect becomes reversible, is lost. So this forms basically the clinical basis or the funda behind considering the repeat dose or the rescue dose of steroid when the pregnancy has continued beyond maybe 7 days or 14 days after having completed the first course of antenatal corticosteroid therapy. As a result of all these inducing effects on the lung, what are the physiological end benefits that are going to be attained? It could be in form of increase in the lung compliance, a better lung volume, decrease in the vascular permeability, and a mature lung parenchyma. So that's about pulmonary benefits. What about extrapulmonary benefits? It is said that there are almost like 300 specific genes which are dispersed all over the body in different tissues, are regulated by betamethasone, through which it is known to induce or accelerate the maturation of various tissues. Specifically with regard to IVH, these steroids are known to induce the expression of vascular endothelial growth factor, which in return promotes angiogenesis in the germinal matrix and thereby having a better circulatory stability. In relation to NEC, the beneficial effect is mediated by accelerating the maturation of the intestinal mucosal barrier. With that, the next question is like which corticosteroid to use. The recommendation is for betamethasone and dexamethasone. So when compared to other steroids like hydrocortisone or prednisolone, like why the advantage with respect to these two is like both are chemically almost same. Only difference being the methyl group at the position C16 are known to readily cross the placenta in their active form. They are devoid of mineralocorticoid activity, cause a relatively weak immunosuppression, and have got a longer duration of action, almost from 12 to 24 hours when compared to hydrocortisone or prednisolone, which lasts for maybe 8 to 10 hours. So within this betamethasone and dexamethasone, which one is superior to the other one? the Cochrane review 2013 done by Brownfoot et al. Showed that there was no significant difference in the rates of neonatal death or RDS when different types of steroids were used. However, there was a significantly decreased rate of IVH in the dexamethasone group. With respect to maternal outcomes or childhood outcomes at 18 months of age, there was no significant difference. On the other side, the Cochrane review 2017 by Roberts et al. Was more favoring towards betamethasone, which showed that there was no significant difference with respect to majority things except for some beneficial effect in relation to RDS, chronic lung disease, and chorioamnitis. But the data was profoundly confounded since it was an indirect comparison rather than direct comparison. I mean to say that the Cochrane review 2013 was more of a dexamethasone versus betamethasone direct comparison, whereas a 17 Cochrane review was a basically studies at one end betamethasone versus placebo, and the other end dexamethasone versus placebo. What does the recommendation say? The ACOG says there's no sufficient evidence to support the recommendation or the superiority of one corticosteroid over the other. Either of the two drugs, depending on the availability, can be chosen. In the Indian scenario, to put a word, the betamethasone which is available is the betamethasone phosphate salt. It is not the betamethasone acetate plus phosphate salt. So this betamethasone phosphate salt basically, see, it is almost like equivalent in case when compared to dexamethasone. So that's one thing. And second thing is like it's got a temperature stability which is on the lower side when temperature stability. And then third thing, with respect to dexamethasones, the very previous articles, like way back in 2000, had said that there are some neurotoxic preservatives which are used, like with relation to dexamethasone, such as sulfide, but it is not proven as such. So having chosen a drug, what is the dose? The principle while dosing the baby is like the desired effect is attained at the lowest possible fetal exposure. That should be the principle. The standard dose should consist of either 12 mg, 2 doses of betamethasone given intramuscularly 24 hours apart, or 4 doses of 6 mg each of dexamethasone administered intramuscularly every 12 hours. With this dosing, it is said that in the pharmacokinetic studies, they have shown that more than 75% of the glucocorticoid receptors in the fetal tissues are occupied. What does the Cochrane meta-analysis say? In fact, there were no studies available for inclusion under the Cochrane meta-analysis, since like no trials included investigated different dosing regimens. What is the route of administration? It is the intramuscular route, which is the recommended route for either of the drugs. Intravenous route is not a choice until unless IM route is contraindicated in a scenario like where there is a severe thrombocytopenia or when there is a setting of like therapeutic anticoagulation. Dexamethasone, with respect to this IV, has any advantage that it can be given intravenous route. With respect to intravenous route, the issue is like the fetus is exposed to higher peak levels of dexamethasone than intramuscular route. Even studies have used oral dexamethasone, which concluded that there is a significantly increased incidence of neonatal sepsis. So what is the interval? There's something called as accelerated dosing. So betamethasone, where we are supposed to space the dose at 24 hours, when the dosing is done at a space of 12 hours, it's nothing but so-called as accelerated dosing, and the preterm delivery is felt to be very imminent. Yeah, there was an RCT trial done by Kadalwal et al. In 2012, which reported that the 12-hour dosing compared to like a 24-hour dosing had no impact in the incidence of RDS. In fact, there was a statistically significant increase in the incidence of NEC. With relation to timing, what is the maximal therapeutic benefit attained? When the steroid dose, excuse me, am I audible?
Yeah. Please continue.
So what is the maximum therapeutic benefit attained? Like it is the therapeutic window between 24 hours after completion of the dose up to 7 days after completion of treatment. What if the delivery happens before completion of the course? There are studies which have compared like partial course versus no steroid. They said that there is a decrease in the mortality almost like the extent of 26%, which is very significant in the partially steroided group. So this gives a clear-cut message. The first dose should be given even if the ability to give the second dose is unlikely. What if the pregnancy continued beyond 7 days after steroid exposure? So as we said in the initial discussion of the mechanism of action, whatever the architectural changes that have been induced because of steroid persist or remain static, whereas the inducing effect or the stimulant effect basically is weaned off as the day goes at beyond 7 days. So the studies have shown that there is an increased risk of RDS for those who delivered after 7 days of steroid exposure. And if the delivery happened after 14 days of steroid exposure, there is an additional increased risk of need for ventilator support and surfactant use. So in this scenario, when the beneficial effect has weaned off, so how to pass on the benefit? Like, can we consider like against steroid? So there comes basically a rescue course. We define rescue course refers to specifically one course of antenatal steroid therapy administered to women who have previously received one full course of steroid but have remained undelivered following completion of this course. What does the evidence say? The Cochrane review in the 2015 said that single course showed be safe with the benefits with respect to respiratory morbidity, and it showed no significant harm in relation to long-term childhood outcome. So what does the guidelines say with respect to rescue dose? So do not administer rescue course routinely. A single rescue course should be considered provided the gestational age criteria is of less than 34 weeks is met. Is it at risk of delivery within the next 7 days? The time intervals in the first course of steroid therapy is at least 7 days, and the risks and benefits are discussed with the woman. Studies have shown that even after like the rescue dose, if the pregnancy continues after 7 days, the steroid effect has been, and they have shown that there is increased risk of RDS. So what to do in this scenario? So should we repeat? So there comes the repeat dose. So it refers to any administration of steroid at regular intervals once the full course of steroid therapy has been previously completed. So it is at every regular intervals. So what does the Cochrane review say? The Cochrane review 2017 by Roberts et al. On repeat doses said that though there was a significant decrease in mortality and morbidity in terms of RDS and IVH, no long-term follow-up data was available to conclude its beneficial effect with respect to neurodevelopment. Very crucial. So going in search further ahead with respect to the significance of repeat dose in the form of other studies. So we have like ACTOR study and the MAX study. In the ACTOR study, the Australian study, which showed that with respect to short-term benefits, yeah, there was a decrease in the RDS, there was a decrease in the duration of mechanical ventilation, but there was a decrease in the weight and head circumference at birth too. And most strikingly, then on a long-term issue, attention disorder was more likely to be in the steroided group. On the other side, the MAX study, where in fact the steroiding was done every 14 days when compared to ACTOR study where the steroiding was repeated every 7 days. Here in this MAX study, they showed no difference with respect to RDS nor mortality, but there was a significant reduction in weight, head circumference, length at birth in the steroided group, and as well as a significant increase in the chances of neurodevelopmental disability, which raises a lot basically concern about the safety profile of using repeat dose of steroids in pregnant ladies. What does the guidelines say? The ACOG says that no more than 2 courses should be used, only up to 34 weeks of gestation, with presume that the previous course completed 14 days back and the preterm birth being imminent in the next 7 days. And the Australian practice, there's no comment about like of the limit on the number of courses. But the gestational age they have limited to 32 plus 6 weeks plus 6 days, and the previous course completed was 7 days back, and the way the imminent preterm birth is imminent in the next 7 days. What about the gestational age considerations? So whatever the data the randomized data that has been available, and then we have been conveying about the beneficial effects of steroid, is keeping in mind the gestation age group of 24 weeks to 34 weeks. What about the either end of the spectrum of the gestation ages? Be less than 24 weeks, and the other end of the spectrum, late preterm and early term babies. What does the evidence say? Coming to less than 24 weeks, we need to strategize for a rational use of antenatal corticosteroids in these extreme preterms. So one thing, by considering the inputs from the parents after they have been counseled about the long-term neurodevelopmental issues and the high mortality rates with respect to these kids. And the second thing, the availability of the expertise and the infrastructure for the neonatal care. Does it act? First of all, yes, alveolar development is known to be detected as early as 22 weeks of gestation, and over and above even the corticoreceptors develop as early as 12 weeks of gestation. Yes, theoretically, it is known to act. What does the clinical evidence say? Basically, we don't have any RCT data available, and nor any studies which basically small studies or cohort studies which are available investigating the long-term outcomes available in this population. In one of the study done by Carlo way back in 2011, which included almost 10,000 neonates born between 22 weeks to 25 weeks of gestation, revealed that in the 22 to 23 weeks, there was no significant benefit with respect to neonatal mortality or morbidity. Whereas between 23 to 24 weeks, there was a significant improvement with respect to mortality and morbidity in the form of either respiratory, intracranial, or gastrointestinal issues. Again, so as I said, there was no long-term follow-up data available with respect to even 23 to 24 weeks of gestation. What is the guidelines? The ACOG recommends administration of steroid can be considered from 23 plus weeks. It's not 22, from 23 weeks. Parents wishes for early intensive care or resuscitation, and the availability of expertise and infrastructure for neonatal care, irrespective of the membrane rupture status and regardless of fetal number. Going to the other end of the gestational age group, the late preterm group, we do know that when compared with late preterm and early term, these late preterm and early term share the same risk of mortality, but when it comes to morbidity and the rate of medical intervention, which is significantly higher in case of late preterm. So can this morbidity and the higher intervention rates can be handled with the use of antenatal corticosteroid was the question. In order to answer this, so we had a multi-center trial, the ARVIND trial in 2016. It had its own benefits and risk at the end of the study. In terms of benefits, it did decrease the rate of severe respiratory morbidity and a significantly lower rate of ETMV in the steroided group. When compared with that, with respect to risk, it had no difference in the rate of RDS, and much more importantly, it had increased the rate of neonatal hypoglycemia, which in fact has its own consequences with respect to neurodevelopment. In order to assess this impact of neonatal hypoglycemia, there were no data available with respect to the severity, the rate of hypoglycemia, and then subsequently the long-term follow-up data on the neurodevelopmental issues in this ALPS trial. What does the guidelines say for late preterm? A single course can be considered when there is a risk of preterm delivery between 34 to 36 weeks plus 36 plus 6 weeks for women who have not received a course of corticosteroid previously, after the risks and benefits are discussed with the woman and the pediatric care providers. And then another gestational age group, that is the early term, gestation between 37 weeks to less than 39 weeks. This picture shows why this consideration of ACS should be given for this gestational age. So this is the graph showing basically the respiratory morbidity of fetus born via cesarean section prior to the onset of labor versus the respiratory morbidity risk in the babies who are born by vaginal delivery. In order to reduce this gap, can we give a trial of antenatal corticosteroid therapy? The evidence going by the ASTERS trial showed that though there was a significant decrease in the NICU admission due to respiratory morbidity, the rate of admission for non-respiratory morbidity was higher in this group. And on the other end, there were no details provided with respect to neonatal hypoglycemia. When the same kids were followed up into the school ages, the analysis of school reports showed that there was a significantly lower performance with respect to academic ability of these children who were steroided earlier. So this raised a concern regarding the long-term safety of antenatal steroid in this early term gestation group. What does the guidelines say? Going by the Canadian guidelines, says that the routine use is not recommended prior to pre-labor cesarean section. With respect to the Australian guidelines, which says that can be considered after 34 plus 6 weeks if there is known fetal lung immaturity. Regarding ACOG and NICE guidelines, they have provided no recommendations with respect to this gestational age group. This slide summarizes the beneficial effects with respect to wide spectrum of gestational age groups. Whatever the data that has been proven with respect to either mortality or morbidity is this gestational age group between 24 to 34 weeks. So for RDS or IVH or NEC and even in long-term form. Whereas the other extreme, less than 24 weeks, between 23 to 24 weeks, there has been a significant reduction in the mortality, but a question mark about a long-term follow-up. And with respect to the late preterm and the early term, there are issues with respect to neurodevelopmental on a long run. What is the role of antenatal corticosteroid in special situations? Here, it could be like diabetes or multiple gestation or PPRM or like any other low resource settings. Like the issue is like there is a lack of data, the randomized control data to conclude for or against these situations. Coming to the low resource settings. So as we all know that on one side, we know that the burden of preterm birth is highest in the low income countries. On the other side, despite we know that like there is a proven efficacy of antenatal corticosteroids in bringing down the mortality and morbidity, only few women in the low resource settings land up receiving these antenatal corticosteroids prior to delivery. There was a study undertaken in trial way back in 2015, which promoted strategies to increase the use of antenatal corticosteroid, which in fact resulted in a substantial increased risk of unnecessary steroid exposure, increased risk of neonatal mortality and maternal infection. The causes, it was hypothesized, may be due to inaccuracy with the gestational age estimation because of lack of regular ANCs and dating scan and other things, and difficulties in predicting the preterm birth. We need to like improvise on this regular ANCs, getting the dating scan done, and improving our clinical acumen and skills in order to predict the preterm birth. Another special scenario where like the mother is diabetic. So we know that steroid has a glycemic effect. So it is known to increase the glucose level, but this lasts for like a transient duration. Maybe it's known to happen like 12 hours after the first dose and up to 5 days after the last dose. It is known to happen both in diabetics and non-diabetics. Once this hyperglycemia, had it been a persistent issue, would have reflected in the form of like fetal hyperglycemia and thereby hyperinsulinemia, causing depression or maturation of the lungs and the cardia. But it's not so, it's a transient phenomenon. What does the international guidelines recommend? So the guidelines say ESA should be administered to diabetic women at the same dosage according to same indications as for the non-diabetic mother. Role of antenatal corticosteroids in PPRA. There has been a significant decrease in neonatal mortality, RDS, IVH, and NEC, even in the setting of PPRM when the single course of antenatal corticosteroid was used. On the other hand, there was no increased risk of chorioamnitis or neonatal sepsis. Even it was said that even with second course of antenatal corticosteroid, it didn't happen. So, there are these studies, even in fact, like the babies who have been delivered after following PPRM have been steroided, or developed RDS, gone back like retrospectively, analyzed for like through histological examination for chorioamnitis. Even those confirmed case of histologically chorioamnitis, the steroid group basically was associated with the neonatal mortality and morbidity. What is the recommendations are? The ACOG recommends the use of steroids to patients with PPROA. Steroids in multiple pregnancy. We do have like a theoretical concerns that the added maternal plasma volume might dilute the drug effect, basically, which is not in fact validated. And another practical concern is like prediction of preterm labor, and thereby optimal timing of steroid therapy is an issue with respect to between pregnancy compared to singletons. So the recommendations, the international guidelines recommend administering steroid with similar guidelines as per the singleton pregnancy. So this slide summarizes the same dosage, same drug, and the same route should be opted either in the setting of multiple fetal pregnancy, pre-gestational diabetes, or gestational diabetes, obesity, or growth restricted. With these overall beneficial effects evidence all through, antenatal corticosteroid therapy remains as one of the most powerful tools in our armamentarium to fight the complications of prematurity. Thank you. Thank you for patient hearing.
Yeah, thank you, Dr. Keerthi, for a wonderful session. Before we start the discussion, one second. Yeah.
Hello, Dr. Prashant.
Yes, sir. Yes, sir. Yes, sir.
Hello, Dr. Keerthi.
Yes, sir.
It's a wonderful presentation on steroids usage.
Bidri sir is there?
Hello.
Thank you, sir.
It's a wonderful presentation and excellent topic you have been chosen for this occasion. And details about the usage of static steroids, when to use, what are the things to begin, unfortunately also even the school studies also you have been studied well. So that shows that the importance of corticosteroid usage in prevention of respiratory disorders is essential much, including preterm and term babies. And on behalf of KNF, you have been selected for Mysore area, especially from Mandya. You are the first fellow who have been selected for this year. And henceforth we are going for Madikeri. So for this academic activities, Dr. Bidri has given very much support for us. And with our boys, Dr. Prashant and Dinkar, we are doing a wonderful job on KNF studies. And today's excellent talk by ARVIND Shenoi also. And no doubt our senior and Dr. Guru Prasad has managing the whole show. And especially for Dr. Prashant and Dinkar. A wonderful presentation. And thank you once again for your presentation. Over to Dr. Prashant, please.
Thank you, sir. Yeah, thank you, sir. And Dr. Dinakar, sir.
Yeah. Prashant.
Yes, sir. Quickly before
Bidri sir is there?
He's yet to join, sir. Not
okay,
joined.
can you, Guru Prasad, sir?
Yeah, I am there. Hello.
Guru Prasad, sir. Dr. Guru Prasad, sir?
Yeah, I am there. Dinakar.
Sir, your voice is not audible.
I am unmuted myself. Just see in the center they have done it.
Okay.
Yes, sir. Yes, sir.
Yeah. Dinakar?
Yeah, we can hear you, sir.
Video is not there. It's all right, I think.
Okay, sir.
Yeah. Can I speak, Prashant?
Yes.
Yes, sir. Yes, sir. Yes, sir. I think Bidri sir came.
Bidri sir is there?
Yeah, he just joined, sir. I'm trying to unmute him.
Okay.
Yeah, he's there, sir.
Bidri sir?
ನಮಸ್ಕಾರ ರೀ ಎಲ್ಲರಿಗೆ ನಮಸ್ಕಾರ ಹೇಳ್ರಿ
ಅಯ್ಯೋ ಗುರುಗಳೇ ನಿಮ್ಗೆ ಬಹಳ ಮಿಸ್ ಮಾಡಿದ್ವಿ ಆಮೇಲೆ ಅವಾಗ್ಲೇ ಬೆಳಗ್ಗೆ ಫಸ್ಟ್ ಬಂದು ಜಾಯಿನ್ ಆಗಿದ್ರಿ ಯು ಜಾಯಿನ್ ಅಂಡ್ ಯು ಲೆಫ್ಟ್ ಸರ್ ಪ್ಲೀಸ್ ಸಿ ಡಾಕ್ಟರ್ ಕೀರ್ತಿ is there in the line. He is from
Mandya.
Mandya. After a long time he is talking from Mandya representative. Please what is it ಇದು what is ನಮ್ಮ advisor for the web ಇದಕ್ಕೆ ಮತ್ತೆ ನೀವು senior man ಸ್ವಲ್ಪ ಅವರಿಗೆಲ್ಲ ಇದು ಕೊಡಿ ಸರ್ ಪ್ಲೀಸ್ ಬ್ಲೆಸ್ ದೆಮ್ ಅಂಡ್ ಬ್ಲೆಸ್ ಅಸ್ ಆಲ್
I welcome you. I welcome Dr. Kirti
Thank
and
you,
all
sir.
the best and my best wishes for the talk.
Thank you, sir. Thank you.
Right, thank you.
yes sir
Sir, I request.
over to Guru Prasad sir.
Yeah, Guru Prasad
audible,
sir, to
Prashant?
please start the session.
Yeah.
Yes, sir. Yes, sir. Yes, sir. In WhatsApp, I've sent you a few questions which has come, and a few
Audible,
Facebook question is with there. Yes, sir. Yes, sir. Yes, sir. Audible, sir. Please go on, sir.
Kirti, excellent presentation, and Arvind, as usual, unbelievable show for such a complex topic. I congratulate both of them for their wonderful presentation.
Thank you.
Before we go to Arvind Shenoi, Kirti, just I thought that I will just add on to whatever you said. And you know that antenatal steroids was described by Liggins as early as 1969 when we were very small children at that time. In experimental animal lambs, he showed a beneficial effect of decreasing RDS. It took nearly 3 years for him. In 1972, he showed it in human trial also that this steroid is effective. Unfortunately, from 1972 to 1990, for nearly 18 years, it was a gray area. Only 1990, Crawley et al., he analyzed 12 RCTs of nearly 3,000 population and demonstrated a very clear beneficial effect of steroids. So unfortunately, if you look at the medical history, subsequently only antenatal steroid administration became the standard of practice for preventing RDS in preterm babies. But very surprisingly, subsequent to 1990 till 2014, it is almost 24 years. The Government of India released operational guidelines in 2014 for antenatal corticosteroid administration. I think I just share a couple of points from that because we are working in India. The members should take very clear message. What it recommends is, as you rightly said, we are going to use dexamethasone as the steroid of choice in our situation. For the reason we don't have the beta-methasone acetate phosphate preparation, which is practiced in the Western world, not for any other reason. Physiologically, beta may be partially superior to dexa, but dexamethasone is equally effective. What it recommends is giving 4 doses, 6 hours apart. What we say is, even an auxiliary nurse midwife, if she comes out with a mother who is in active labor, about to deliver a preterm baby, even before referral, she should give a shot of dexamethasone. That is the recommendation. I think this is administration of steroid is probably the magic bullet in perinatal medicine. Such a wonderful low-cost intervention which enhances the lung maturity. There is no second word about it. I think with your literature presentation, you convinced all the participants that antenatal steroid is very useful. And they do recommend for pregnancies from 24 to 34 weeks presently, 1 course of corticosteroid without repeating subsequently. But you nicely discussed for the benefit of fellows and postgraduates when it need to be considered a repeat dose, all that. I think you did a great presentation. That should be the take-home message as far as antenatal steroids are concerned. Dr. Arvind, I am audible to you.
Sir,
Arvind?
please go ahead. Yes, sir. Please go ahead.
Wonderful presentation. It was a great presentation. You made such a complex topic so simple. And the take-home message from your side is, we have understood very little about bronchopulmonary dysplasia. The pathophysiology is very complex and it's multifactorial. Terminally, it lands up with airway edema, inflammation, and bronchospasm. So the gold standard for treatment is multifaceted approach. And for decades, we are using diuretics, bronchodilators, and you very cautiously discussed the role of steroids, early versus late, if at all it is necessary, when it is indicated, and parenteral preparation, oral preparation, and then inhalation forms also. Just to add to your presentation, you were, because inflammation is becoming, chorioamnionitis is becoming an important risk factor for bronchopulmonary dysplasia. Recently, we concluded enrolling nearly 350 stillbirths and 350 neonatal deaths for our project study. And interestingly, all the placentas of these deaths have been analyzed both histopathologically and by multiplex PCR. I'm surprised to say to you that 20% of these situations you have isolated ureaplasma uvulaticum. That means out of 700, 20% of them, nearly 140. That it is an eye opener. We should not think that ureaplasma uvulaticum is not there in developing countries like ours, because we have not looked at it. All these specimens were subjected to multiplex PCR. Probably in that context, macular antibiotics are widely being promoted for clinical use in antenatal period in high-risk pregnancies. I think that's all I can tell you. Otherwise, your presentation, you made it very clear. From my side, there are a couple of questions that I have noted down. What is the effect of blood transfusion practices on bronchopulmonary dysplasia? And a word about term babies with chronic lung disease.
Thank you, Guru. Actually, you're the Guru, I am the Shishya. So I don't know how to answer these questions, but I'll try my best. Number one, the important point of transfusion I didn't touch on is because there's clear evidence now that possibly we should be using erythropoietin, reducing the transfusions, giving more iron. But as of now, it's not become standard of care. Second thing is the transfusion guidelines have not changed in relation to BPD. We follow the current same transfusion guideline based on oxygen requirement. We give transfuse at a higher level if the baby is on oxygen or on respiratory support, and at a lower level if the baby is on off oxygen or in room air. So as BPD babies are on oxygen, the thresholds, transfusion thresholds by the British Society or any of the other societies remain unchanged. The second point you asked was, what was it again? Prashant, can you help me? What was the second point?
It's about the term your views on BPD term baby.
Term BPD, where the issue is not so much developmental arrest as much as lung injury, and the management doesn't change much except that you may have to consider use of steroids little less carefully, as if I may put it that way, or you can use little more aggressively in the term than you do in the preterm. Definitely in the preterm, as Keerthi has shown, steroids don't seem to be a very good thing for the brain. So probably we should not use even postnatally steroids in the preterm, but in the term BPD, which in our country is a common problem following meconium aspiration, you could possibly consider, though again with caution. Sorry, Guru, I hope it answers the question.
I think Guru Prasad sir
Yes.
logged out. Anyway, sir, Dinakar sir, please ask question from the Facebook, sir. Over to you, sir.
Okay, wait, hold on. ಅದನ್ನ ಆನ್ ಮಾಡು ಅದನ್ನ. ಅದು ಓಪನ್ ಮಾಡು. Sir, namaste, sir. Dr. Dinkar here, sir. Both the speakers. First, we will take Dr. Arvind Shenoi, sir. Sir, what is the correct definition of BPD? In 2001, NICHD has told what you have explained in your slide. That is less than 32 weeks, more than 32 weeks, mild, moderate, severe. That what you have showed. But later in 2018, there is one more classification, like just now you have added in your slide. Just I am not so clear what he is telling, because he has typed so much. I am not so clear because many articles are depending on 2001 NICHD a classification. They are writing the articles, but then why 2018 they have written less than 32 weeker with lung pathology should be there in the X-ray with oxygen. In that grade 1, grade 2, grade 3 is there. Now, if I want to teach my postgraduates or fellows, what should I tell? Whether mild, moderate, severe, or grade 1, grade 2, grade 3? Dr. Sir, over to you, sir. Arvind Shenoi, sir.
I thank the questioner because it's a very difficult question to answer, because many people question whether BPD is one disease itself or a combination of many diseases. That is why the confusion has come. So if you are convinced that this BPD is one disease, then you can have a classification. If it is many diseases, you can't have a classification. So the best way to understand this, or if you want for teaching purpose, BPD is a syndrome. If your baby requires any kind of pressure or ventilation at 36 weeks, this is severe BPD. If the baby does not require more than 30% and does not require pressure, this is moderate. And if it is able to maintain saturations in room air, it is mild. I think the NICHD initial classification was functional and a working classification for all of us. For research purposes, now they are splitting mild and moderate BPD from the severe BPD, and that is why 1, 2, 3 has come. I did not introduce it because it will increase the confusion. Much better is for us clinicians to go by the clinical definition, which the NICHD very clearly gave it, very simple to understand. Room air, less than 30%, any pressure or more than 30%, mild, moderate, severe. So for practical purposes, for teaching, for work in the unit, we use that classification. For research purposes, the other classifications. Mind you, the room air test, which was described by Dr. Walsh, very clearly tells you, cuts out some other babies who would otherwise have been called mild BPD. So that brings it down succinctly to those babies and also tells you which are the ones you need to treat. I hope I have answered the question, but the confusion continues because as
Sir,
you
the same thing questions, yes, sir. Yeah, 2018 classification, 28 days requiring oxygenation is removed. Do you think or do you tell us we should follow still 28 days oxygenation is required?
No, it's 36 weeks PMA. 28 days has been removed. That I mentioned.
Removed. Okay.
6
Sir.
weeks post-menstrual age. Yeah.
Okay, sir. Then what is it? Definitions of needing oxygen till 36 weeks. Is it same for 24 weeks delivered baby and 32 weeks delivered baby? Is it same?
See, the 32 weeks as I made, for a 32 weeks and beyond, take EDD, that is 8 weeks beyond. For less than 32, take as 36 weeks.
Okay, I think so. Understood. Okay. 1, 2, 3. Okay. Why antenatal steroid does not decrease BPD? According to the Cochrane review, it is from Delhi, sir. Cochrane review, RR interval, relative, this thing, RR interval 0.86, confidence interval is more than 1. RR is good, but confidence interval is more than 1. The diamond is on null line in most of studies. Why antenatal steroids it does not decrease BPD? You have told in your things, but why it is not decreased, you didn't tell.
I asked question to Dr. Keerthi, so he will answer.
Why it is not decreased? Because diamond is also under null line. I think so. He is a very good researcher. He is telling about RR 0.86 confidence interval. Very good question. Sir, in pathophysiology development of BPD, you have told there is new BPD and old BPD concept. What it means exactly? Arvind, should I say?
Yeah. New BPD refers to babies who have had ventilation-induced lung injury. To put it very clearly, is the old BPD. Ventilation-induced lung injury, old BPD. New BPD is very premature baby, exposed to chorioamnitis, then is having oxygen toxicity and so many other injuries, and then develops oxygen dependence, sometimes requiring mechanical ventilation. That would be the new BPD. So this is my understanding, to put it very simplistically. There will be areas of overlap, but remember, old BPD, damage done by the neonatologist. New BPD, nature and neonatologist both doing the damage. I hope it answers.
Yes, sir. Sir, can I add if you don't mind, sir?
Please, sir.
Okay. So this is from Selva Kumar, Tamil Nadu. Sir, new BPD. What sir has told is correct. During the development, because lung and pulmonary alveoli and interstitium, 3 things is not developing properly. If the baby delivers early, sensitivity will come. Old BPD means Old means it is baby developed, but it is, as sir told, we are XXXS, all traumas we are damaging. That is called old BPD. That's all, sir. Sir, one more thing for you, sir. Dr. Arvind Shenoi, sir.
Yes, sir. Yes,
Sir,
sir.
fetal PaO2 is very low. PCO2 is little higher. But after birth, we keep PaO2 high and PaCO2 low. This is the one causing oxidative damage and causing the death and BPD?
Good question, but how will you answer that? Very difficult to have an experimental model. You can't put the baby back in uterus. No? It's a difficult, very interesting research question, but difficult to answer. But my understanding is that the physiology in utero is different from physiology ex utero, and the physiology in utero is tuned to having survival and growth and thriving at low PO2s, while ex utero, all of us require a different level of PO2 and PCO2 for various changes which occur across the body. But to answer, is this the cause, is difficult to answer because you can't maintain a baby at that kind of levels ex utero. Dr. Guru Prasad probably can answer that better than me.
I think I agree. Yeah, I think I agree with what Arvind is telling. You have to tailor make the needs of the infant ex utero. Just to add to that, just Dinakar, look at the steroid. You say that antenatal administered steroid when the mother is in active labor, even at that almost at the verge of delivery, few hours later, still they will have partial benefit and enhancement of the lung maturity. You please administer. Very interestingly, you administer steroid immediately after a preterm baby is born. It has no effect on the lung. We are unable to explain why. You administer intratracheally or intravenously by or any other route. The same drug, when it is administered just a couple of hours to the mother, is going to be effective. This is something nature's game. I think we have understood very little about it. I think.
Yeah. Okay. Sir, Dr. Arvind Shenoi, sir, same question continues from Pondicherry. So what he is telling is, sir, keeping little, not means permissible PaCO2 little high, not more than 65%. PS, same continuation, one more question. So I'm just putting to the same. And PaO2, is it better, sir? As if we are mimicking the uterus. Is it okay? PaCO2 and PaO2? Dr. Arvind Shenoi, sir.
I think Dr. Guru Prasad gave a very convincing reply. You have to, the physiology ex utero is different from in utero. So I don't think you can compare the two together. The physiologies are totally different. Permissive hypercapnia has been described with PaCO2s up to 60. It has to be taken care that the baby does not become acidotic at the same time. So that is my take on it.
I think we have to tailor make decision as a clinician at that point of time for a given infant, looking comprehensively what is the problem with the infant. I think we talk about permissive hypercarbia, all that. I think that's what exactly the participant means. It all depends on what is the clinical scenario at that time. Yes, Dinakar.
Yeah, one more question, sir. It is from Kerala. Injection vitamin A, 5,000 units alternate day, IM for 4 weeks, totally 28 injections will come. Is it really worth? At present, it is not available also. What to do now? Any other way to give this medication? Because in Nelson it is written, all the books it is written, articles it is written, it is not available at present. But if it is my baby, I don't want to give the injection alternate days for each thigh, 5,000 units. Sir, what is your opinion?
I hope the question is for me. I'll answer. In our unit, we give the same dose orally. But no studies have been done showing that it is equivalent. The studies are on IM. Since it's not available, I think vitamin A can be given orally, and that is what we do. But I don't have a RCT to prove that.
Okay. Sir, orally, is it helpful, sir? Useful?
I hope it is.
Okay.
It is BPD you
Sir.
attribute it as an oxidative stress, you know, Dinakar. So antioxidants, these are all adjunctives that have been explored in the management of BPD.
Okay, sir, one more thing. When DEXA or hydro, whether early or late, chances of CP, cerebral palsy, more than inhaled steroid, whether to start early or late, what is the dose and interval? How many doses? Means dexamethasone or hydrocortisone, which is better? Sir, you told, but they're asking dexamethasone is better, hydrocortisone is better, whether to start early is better, late is better, whether it because it causes cerebral palsy, and whether inhaled steroid, which one to use? What is the dose of inhaled steroid? How many days we should give?
My whole talk was emphasizing not to give.
Yeah.
So please don't give. If you have
And I think Arvind has made it very clear. Even the dosing, he has shared his presentation, which will be there in the video. The residents can retrieve it and see. Very clearly mentioned what is the recommendation for individual steroids, dosing and duration. Both is very clearly discussed in his presentation.
Okay, sir, related to the same question, it is related to the DEXA. What is the difference in both the regimes? Whether mini DEXA is better or DART is better?
See, very clearly I have told you there are many regimes. You can use whichever you want, but my emphasis is don't use. If you have to give yourself. It may help you. Don't
Dinakar asking us so many questions on steroids is like provoking Chinese king.
No, sir. Now COVID actually, what sir was telling from that time is actually Arvind Shenoy sir told more than 10 times before cytokine storms will come, I will kill that with the steroid. That is the reason I think people have got excited and they're asking.
That's what I told. Indians have taken 25 years to make it operational guideline, though knowingly well steroid is effective. We think 100 times before it is implemented in clinical practice. Subsequently, you are proved it is going to work in COVID as well, just 5 years later.
Sir, azithromycin can we give in a preterm baby? Because it is written less than 5 years or 2 years, we should not give. How, any problem, sir? Because prescription is telling should not be given.
See, the
Arvind Shenoy, sir.
In a trial basis, it probably can be used. As of now, there is no proven benefit. It was news to me what Guru Prasad said that urea plasma is also present in our country. Probably as a trial, we should see whether it will help. I am not sure it helps. There are a lot of studies which say it might help, and there are a large number of studies which say it doesn't help. Because unless urea plasma is a main problem in our country, I don't think it will help much. So as a trial, if you use it, may help. But under supervision, taking informed consent, you should use it.
Now, what is residents' concern, Arvind? Macrolides, especially azithromycin, clarithromycin.
One more question. I heard.
Dinakar. Use of macrolides in newborns and young infants is very clearly deferred. That's what the residents' concern is. Though we used in the past erythromycin for a couple of indications in neonatal practice, BGR or infantile hypertrophic pylori stenosis. So as such, it is not a commonly used drug. It is still to be researched before it is put into clinical practice.
Yes, sir. I heard about one more question. Sir, I heard about BPD calculator. Is it useful? Are you using? If you are using, when to use? Arvind Shenoy, sir.
I'm not using. I told you what I am using. That chest X-ray calculator and Greenoff, we are using that. But otherwise, I don't use the BPD calculator.
Okay, sir, you are asking, actually that was a 17th question, but now only I am telling you. Sir, how to tell if it is mild, moderate, severe other than oxygen in the X-ray? Like RDS, we tell mild, moderate, hazy, ground glass. How you are going to differentiate between BPD in the X-ray? Because you that is the question he has asked you. In X-ray, how you are going to differentiate mild, moderate, severe?
A very interesting question. Thank you. the actual thing is you should be able to distinguish severe in the X-ray, because that is the one you will need to use steroids. You don't really need to predict mild or moderate. That's why that score I gave you, it tells you if it is 4 or more out of 8, you're dealing with severe BPD. That is the baby who is likely to go on to steroids. That is the one you have to predict. Mild and moderate, you can wait and see if the baby comes off, because you have to wait till 36 PMA. So there's no need for you to predict it at 7 days of age. So use the X-ray. It helps you predict, and that you can decide whether you will want to use steroids or other things in that baby. So prediction of mild and moderate, not an issue. Prediction of severe is an issue. Those are the babies where you need to act fast and put it out.
Yes, sir. Sir, and one more thing, please hold on the line. Okay. What is that? Okay. Sir, you have another 7 questions. Please hold on, sir. Can I take Dr. Keerthi?
Yes,
Please
sir.
go ahead, sir. He will answer those 7 also.
No, sir. No. What is the least gestational age mother can receive steroids? I think so. He is asking what is it, viable period, or which is permeable? What is a viable time? I think so.
The thing is like, it should basically differs on the regional things. So as per the guidelines, they said like between 23 to 24 weeks and not between 22 to 23 weeks. In fact, they're saying like 23 could be the new 24. So as per the guidelines, between 23 to 24 weeks, it has been proven that the mortality and the morbidity, I mean to say short-term morbidity, have been brought down significantly. So there is evidence. So can be tried between 23 to 24 weeks.
Yeah, 23 weeks. Suppose if baby delivers 22, it is my own question. Sorry, he didn't ask you. If it is delivered at 22, can I give?
No, sir. As of now, no.
Dinakar, that's what we said. The operational guidelines of Government of India recommends 24 to 34 weeks, because that we define as the period of viability in our context. Maybe in the Western world, they may say 23, 22 in the US and European countries, wherein they have facilities to salvage.
Yeah.
As it stands now, I think 24 weeks should be taken as the cutoff. As Keerthi said, another 1 week is flexible.
Weeks. Yeah. Okay, sir. Thank you. 24 weeks, please.
Yeah.
What is this? Ramalinga. Why repeat dose is necessary, Dr. Keerthi?
As I said, like when the setting is like something like in the 26 weeks, maybe the pregnant lady has gone into imminent delivery. There are like signs of imminent delivery, and the antenatal corticosteroid first course has been given. But with due course, like she continues her pregnancy, she's not yet delivered. And maybe like 10 days or maybe like 14 days later, again, she poses the risk of like imminent delivery. In that scenario, it has been said that, so there are, after the course of almost like 14 days, after completing the initial course, there can be posing an increased risk of RDS. So in order to tackle this, yes, we can give a rescue course when the time, depending on the considering the gestational age and as well as the time lapse between the last completed course and as well as whether the birth is imminent in another 7 days.
Yes. So why repeat dose? I think so. Understood, sir. We'll go to the next. So after 7 days of the first dose, if it is threatened, yes, or after 14 days, once again, if it is there, better to give. Is there any difference in beneficial effect in a simple preterm baby or preterm with IUGR? Is there any problem? Both is asking beneficial and problem, simple preterm or preterm IUGR with giving steroid to the mother.
Yeah, the issue is like, first of all, there are no quality data, randomized data available. So there, in fact, like in the ACT trial, which was like targeting the IUGR babies, they have showed that basically the arm-wise, like there was like the weight criteria was almost like less than 10 centile even at birth and even into age of almost 2 years age group. So with respect to other beneficial effects, the RDS and other things, like it continues, though it could be like because of either exogenously administered steroid or maybe the endogenously generating steroids. So as of now, the guidelines is in case of like IUGR babies or AGA babies, like as such, continue with the steroids, weighing the benefit and the risk things.
Yes. So what is the mechanism involved in prevention of IVH and NEC? I read what is the benefit about the lungs in many articles, but IVH and NEC, how it will decrease. And I read how it goes PD also I got, but IVH and NEC
Yes,
is
sir.
asking.
IVH, as I said, like it is known to induce the expression of the so-called vascular endothelial growth factors. These factors are known to stimulate the angiogenesis in the germinal matrix and thereby attaining a better circulatory stability. So that is with respect to IVH. And with respect to NEC, it is known to regulate the accelerate the maturation of the intestinal mucosal barrier. So in that way, it has a beneficial effect with respect to NEC and as well as IVH.
Yeah, Tinekar, I just add on to what Keerthi said, absolutely fine. Initially, we were thinking your RDS severity and the incidence both will come down by administering steroids. And indirectly, that will take care of PDA, IVH, and necrotizing enterocolitis. But evidence has very clearly shown, independent of its beneficial effect on RDS, it enhances the maturity of the germinal matrix and the gut epithelium also, independent of its effect on RDS. So antenatal administered steroid enhances maturity of literally in every organ in the body, for that matter. It won't selectively act on the lung of the fetus.
Yes, sir.
Yeah.
Why more than 34 weeks gestational age mother should not receive antenatal corticosteroids? More than 34 weeks gestational age mother should not receive antenatal corticosteroids.
Means to say first course, sir? First course or risk?
No. First course. The following is second. It's the same thing. Second, like same thing they have asked.
Yeah, the consideration, the guideline says that one course can be considered beyond 34 weeks up to 36 weeks, 6 days. So presuming that she has not received the initial steroid in the previous gestation ages, it can be considered. So if at all like the issue is like there are chances of hypoglycemia. In fact, the cause for the hypoglycemia as such, like it's been not well documented, could be related to the insulin effect or could be related to the feeding being not established like in immediate postnatal life, or could be related to like interference with respect to glucogenesis by the steroid. So because of the impact of the hypoglycemia, that raises the concern. And with respect to like the severity of this, the glucose levels and the rate at which like this hypoglycemia happens, and subsequently once the insult has set in, over the long term basically follow-up data with respect to neurodevelopmental milestones, those things are not available. So it remains a question mark. So though it has come down with respect to short-term morbidity, it has come down. With respect to long-term, it raises a concern since there is a positive data. So as per the guidelines, a single course can be considered weighing the benefits and the risk. Otherwise, it's not a straightforward consideration with respect to gestation age of 34 to 36 weeks.
Okay, so Keerthi, what you told is, suppose if mother received previously, previously means around 30 weeker, if she receives one dose, after 34 week, after 34 weeks, need not be given.
Yes.
Because if she is not received, give one more dose.
Yeah.
The same thing. Yeah. Same thing.
That, there is another scenario may arise, like basically she has received the first course maybe at like 32 weeks. Maybe like she was at risk to 32 weeks or 30 weeks, but the things like whatever the imminent delivery what expected hasn't happened, and so basically the second dose or the dosage completion was not done. So the story basically the dosage was withheld, and then subsequently she has continued pregnancy, and then at a later date, maybe near 34, just after 34 weeks, basically she has again come back with imminent risk of preterm delivery. In that scenario, yeah, maybe like they say, like weighing the benefits and the risk, you can consider either 1 or 2 doses of steroid in that scenario.
Yeah, you told just now about hypoglycemia.
Yeah.
Hypoglycemia to a neonate. Can
Yes,
you
sir.
just, because the same question, just I am asking you in my language, why baby will develop hypoglycemia?
That's what, sir. Like as such, like things are not clear. Like, so it could be either three mechanisms they have postulated. One is this: whatever the transient hyperglycemia happens because of the glycemic effect of the steroids, which reflects in the basically the fetus circulation, and in return there is hyperinsulinemia. Same thing which happens like in diabetic infants of diabetic mother. So this hyperinsulinemia basically causes the rebound hypoglycemia. One thing. Or second thing, like in immediate postnatal life, the delay in the establishment of the feeding or the feeding practices. And the third things like basically steroids have been known to regulate the rate limiting enzymes which are involved in the gluconeogenesis process. So it is known to inhibit those enzymes. So these are some of the things like which have been postulated, but it's not confirmed through what mechanism there is an increased risk of hypoglycemia for the babies who are there in that gestation age group.
Yeah, there is one same thing. Mother received 30-weeker 1 dose. 2 weeks is passed, but mother is delivering vaginally because it is also delivery because she is having the pain already 3 centimeter. 3 centimeter cervical dilatation is there. Already she is delivering almost 3 centimeter. Okay.
So the last course was completed 2 weeks back.
2 weeks back. So
Okay.
she's already in the coming with almost impending labor, but it is vaginal. It is not CS. Is there any difference between cesarean section or vaginal delivery to give the injection?
No, in that gestational age, as the studies haven't shown any difference with respect to mode of delivery. Maybe only after like 34 weeks, maybe it does matter. But in that gestational age group, 32 weeks, the mode of delivery wouldn't matter as such. So what we can consider is like since like 2 weeks has lapsed almost like after completing the first course, maybe like about to deliver, maybe in an hour or so, something like that, we can consider at least single rescue dose of steroid. If not full course, at least a dose of rescue steroid.
I think about that point Keerthi has made very clear. Give 1 dose of steroid even if the mother is going to deliver in the next few minutes or couple of hours, Dinakar. There has been very clearly demonstrated partial benefit on the lung maturity. You don't think that she is going to deliver, it is not going to be useful. That's what Government of India policy statement has very clearly mentioned.
Sir. Yeah. Okay. Now can I take Dr. Arvind Shenoi, sir, please? Gurugale?
Sir, Keerthi is answering very nicely, sir.
No. Keerthi is having another 4 questions. Gurugale, Saraswati Putrare, Alle iri. What is BPD spells? Is it like PPHN or like an acute asthma? Why it occurs? How to manage?
Okay. See, the thing which I didn't dwell into is one of the problems with the BPD is pulmonary hypertension. And they can have cyanotic spells very similar, where they have an acute rise in pulmonary pressure and they go blue. It is similar. And yes, the treatment is using bronchodilators. So inhaled bronchodilators are the treatment. And actually, I have 2 other questions here in the chat box, which I also thought would be worth answering. One is somebody has asked me about, with your permission, sir, somebody has asked me about fluid restriction. Can we use fluid restriction instead of diuretic therapy? Some Dr. KK has asked. So I would like to answer saying that fluid restriction with adequate nutrition is very important. So when you restrict fluid, we usually don't go above 120 ml per kilo. Make sure that you're giving adequate calories, because malnutrition adds on to the problem of BPD. The second question somebody has answered is BPD is a costly affair. Dr. Rajkumar Marol has asked how to deal with financial issues. See, the financial issue comes basically because these babies stay in the hospital for a very long time or on oxygen. And the biggest tragedy comes is when they develop a BPD spell and sometimes may even die of it. But yeah, I've had one bad episode which happened where the baby has stayed for a couple of months and dies of a BPD spell. So these are the problems of BPD. And that's why the emphasis on the lecture is on prevention. Treatment of BPD spells, treatment of pulmonary hypertension is very difficult. You have to give sildenafil. IONO has not been shown to be of benefit. It becomes a very complex issue. And these babies require long-term bronchodilator therapy and may even require home oxygen. So these are the problem. In short, BPD cells treat with oxygen, bronchodilators,
Hello?
adequate fluids.
Guru Prasad sir?
Yeah. I think Arvind has made the point very clear. Some practical issues. So I just wanted to know from Arvind, what is the protocol in city of Bangalore if they are going home, a baby with bronchopulmonary dysplasia? How do you arrange home monitoring in terms of pulse oximetry, oxygen, and approximately what advice are they provided with any resuscitation kits? All that we have a couple of babies who have been discharged. Arranging all this is very difficult. It must have been streamlined in Bangalore. What do you have to say, Dr. Arvind?
It is not streamlined. It is really a problem like you have this thing. Number one, you need to ensure oxygen with a backup supply. So if you are sending home an oxygen concentrator, you also need a cylinder because the electricity may fail or the concentrator may fail. So you need to teach the parents how to use the concentrator, how to use the cylinder, how to open the cylinder, and including make sure that they get the right size spanner, because sometimes cylinder comes home but spanner doesn't come home. All parents need to be taught CPR. They need to be taught how to manage a BPD spell, how to increase the concentration. They need to be told how to use a pulse oximeter. They have to be told how to distinguish probe, loosening or probe failure versus actually the baby becoming bad. So it is a very difficult problem. Plus, they also need to know that having oxygen in the house is a fire hazard. So they need to have appropriate instructions to avoid anything inflammable near the child, because oxygen promotes, as you know, fire. It's a very complex thing. The best thing is not to have it. Sending home is a nightmare. And the whole talk, that's why I geared towards prevention, because once it occurs, you are in very bad shape.
Yeah.
Sir, one more thing for you. I think so. There are two things I read in the journals. Proven therapy, not proven therapy. In not proven therapy, breath, fluids, restriction of fluids, or diuretics. It is meant when pulmonary edema is there. Why unnecessarily all the books are telling, once it is not proven therapy, if it is there is no PDA, why to do this? Why to follow? Arvind Shenoi sir.
Sir, that light above your head is very pretty, and it actually tells you about BPD. There are many factors when you're dealing with the extreme preterm birth. Okay, like each of those light, I can count. One is PDA, one is fluid therapy, one is use of steroids, one is the mechanical ventilator settings, how to get them on CPAP. So all things are interrelated. What has been clearly shown is fluid overload is bad in BPD and is associated with worse outcome. So then you keep the fluid low. Obviously, you have a baby who doesn't have a PDA, and where you feel for nutritional purposes you want to increase the fluids, you could possibly do so, knowing fully well that if you go very high and land up with overload, you are actually worsening the outcome. Like that beautiful light above you, there are many points which are interlinked in managing this baby. And thank you so much. Had I known it, I would have put the photograph on the first slide.
Sir, one last. What bronchodilator you are using? Are you using any inhaled bronchodilator?
I use salbutamol, and I am using it whenever there is wheeze or there is bronchospasm.
Okay, sir, steroid budesonide once again you are using, because many people they are using inhaled budesonide steroid. Are you using?
No, sir. No, sir. As clearly shown in studies, it is not beneficial. And in most of the studies, the treating neonatologists also give IV steroids along with inhaled. So consequently, it's better to use, if you want to use steroid, please use an injectable steroid in the dose you think appropriate and for reasons which you are very clear why you are using it, because there is always a price you have to pay for the steroid.
Yeah. Sir, what is classic BPD? Atypical BPD. You told it.
Sir, what people have found is there is a small class of BPD where the babies did not have much respiratory illness and then slowly started getting oxygen requirement. This used to be called, when we were doing DM, Wilson-McKitty syndrome.
Yeah.
It is now called atypical BPD. And these babies slowly become oxygen dependent, that by the time they reach 36 weeks, they are requiring some amount of oxygen. This is called as atypical BPD. And this is believed to be a separate disease because the cytokine markers are different from typical BPD. But the treatment as of now is no different. We need to treat them like any BPD, but once we understand the disease process better, maybe newer therapies will come.
Hello, sir. Yeah. Sir, what is the difference between MIST and LISA? Is it same or something different?
That question is for you because I didn't talk about surfactant.
LISA or MIST?
Sir, MIST and LISA are the same things. And Dinkar, you need another talk on that.
Okay. Okay, sir. Thank you. I think so. Your questions are over.
Yeah, I think Dr. Ankur has one question.
Receiving hydrocortisone medical condition, still we should give Dexa or Beta dose to the mother. Dr. Keerthi.
Sorry, sir, I didn't get your question.
If mother is receiving hydrocortisone for some medical conditions, still we should give Dexa Beta. Dexa or Beta dose, is the dose is same or we should give? And at the same time, he has asked one more question. If mother is obese, fat, do you think we need more dose?
No.
Both questions he has asked.
Yeah, with respect to the second question, I'll take up that. So they have proved that the guidelines, the dosage and everything remains the same for like obesity or BMI, like with moribund obesity, it continues to be the same. The dosage doesn't change, like even in multiple gestation as such, that there's nothing like dilution effect, need to increase or alter the dose or the frequency, no, nothing like that as such. It remains to be the same even in obese mothers. And another first question, what it was like the mother is already on hydrocortisone. So, and then is there any need for like as such? So as such, like the hydrocortisone, whatever the mother is receiving as such, like it, as I said, like in my presentation, there's something called as an enzyme called as 11-beta-hydroxysteroid dehydrogenase, which is known to degrade this hydrocortisone and prednisone, but not so in the case of like betamethasone and dexamethasone. So it is there readily available basically in the active form in the fetal circulation in case of betamethasone and dexamethasone, but not so in case of like other steroids. So it needs to be considered even though the mother is like receiving hydrocortisone, presuming that the added on the burden of like immunosuppression and other things, like how far even the steroid needs to be considered, maybe that should be looked in.
Yeah. So whatever mother is receiving, better to give betamethasone is better. Okay. Last question, sir. What they have asked is, sir, mother is now impending, almost delivering. She might take within 6 to 4 hours. So, or within any time, we know that within 1 day, 2 days, she will deliver. Can we, our own regime, can we practice like giving the betamethasone? So 12 milligram BD into 2 days. Instead of that, can we go for more dose, less interval? That's what the question is.
No, sir. It's clear cut. No, there is no role for accelerated dosing, as I said. So to quote one of the studies done by Carlo, even they said like there is no difference with respect to morbidity or mortality. In fact, like there was increased incidence of NEC when the accelerated dosing was done, where like in place of like 24 hours gapping, when the dose was reduced to like every 12 hours. So with respect to betamethasone, it did land an increase in the incidence of NEC. So, and at the other end, like there was no beneficial effects too. So at the worst, like it says that like it's always partial course is always better than nothing or no steroid. So go ahead and give at least one feasible dose of steroid, even if the basically second dose can be completed as such.
Thank you very much. Guru Prasad sir, over to you. Sir,
Yeah,
all the questions are over.
Yeah, first of all, thank you, Dinakar, for arranging Dr. Arvind, Keerthi.
Dr. Ankur, last question, sir.
Yeah,
Dr. Ankur has raised hands for a very long time. Dr. Ankur,
Arvind sir, I'm really sorry. Good evening, sir. Thank you for such a lovely presentation. I know I am taking your time. Just I will ask a small question, sir. Actually, there was an Mahin Dalera did a systematic analysis of 184 citations and 12 randomized controlled trials. And it was published in 2017, which says that the intranasal inhaled corticosteroids have a good outcome with not so much adverse effects noted among all the studies which they have analyzed in that meta-analysis. And based on that, sir, we were practicing in my old hospital we were starting the baby on inhaled steroids on day 1. And really don't know, sir, that it was a part of study also to come out that how are the things and how much we were preventing BPD, but we were doing that, sir. And it's a meta-analysis, sir. I will share that, and it's published in BMJ from Canada.
Ankur, the problem with these are the long-term outcomes are not specified. So before you use anything, because if you start early on day 1, you are going to give a large number of babies who don't require the drug. And even those people who have done long-term studies on inhaled steroids, whatever the route, they have found the neurodevelopmental outcomes in these preterms are low. So you must be very cautious before using. And certainly, I don't think early steroids has a role till we understand. Because the minute you say early, you will be probably giving almost every baby born less than 28 weeks this inhaled steroid, because I don't think many babies less than 28 hours will not have respiratory distress. So then you'll end up giving every baby, and there is a possibility that some of these babies may never have required the drug at all, because by the time they reach 36 weeks PMA, they may have been off oxygen, and you may attribute that for the steroid which you have given. So be careful.
True, sir.
Before you.
True, sir. Actually, we were attributing it to the steroid that because we started on day 1, it was more of preventive rather than treating. So yeah, sir. The results may not be true, sir. Actually, it might not require.
And it becomes like prophylactic surfactant, which now, as you know, as saying, is no longer considered as good as early surfactant. So I would be very skeptical giving every baby steroid for whatever reason. My reading says steroids are dangerous, they're poisonous, use only if absolutely necessary.
And sir, one last question, one small question that, sir, is the total volume really matters if we are on full feeds for the baby? Most of the babies having BPD, we are mostly on the full feeds for the baby. We are not on IV fluids. So is that total volume or reduction of the volume also matters on the feeds if we are giving the mother's milk or whatever it is?
Ankur, you should attend Dinkar's echocardiogram workshop, so that you can tell whether there is adequate fluid, inadequate fluid, and if your assessment is hemodynamically correct, then only you can say you're giving the right fluid. So
Thank you, sir. Thank you. Thanks a lot, sir. Thanks.
And Prashant?
Yes, sir. Yes, sir.
Can you unmute Dr. Susan John, because she's from Kerala? She wants to ask some questions. Susan John.
Yeah, I'm doing, sir. I'm doing.
Please. And call her Susan John.
Yeah.
Yaku aglilva?
Actor. 1 second. It sometimes take a few seconds to get unmuted.
Nodi Lakshmi Putrarinda ivattu sir. With Saraswati Putrarinda now kaltvi. Thank you very much, sir.
ದಿನಕರ್ ಡಿನ್ನರ್ ಟೈಮ್ ಆಯ್ತು, ಎಲ್ಲ ವ್ಯವಸ್ಥೆ ಮಾಡಿದಿರಲ್ಲ?
ಆಯ್ತು ಸರ್. ಓಕೆ, ಪ್ರಶಾಂತ ಕ್ಲೋಸ್ ಮಾಡು. ಪ್ರಶಾಂತ್.
Yes, sir.
Arvind, it was very nice. We are meeting only in webinars and conferences. Shortly, we should meet person to person sometime and relax. Yeah.
Post-COVID. Thank you so much. Thank you.
Thank you, sir. Thank you,
Nice.
both the speakers. Guru Prasad, sir, thank you. And all the NNF members, thank you. Prashant.
Thank you, sir. Thank you. Wonderful
Well done,
session.
Kirti. Well done, Kirti. Yeah.
Thank you, sir.
Thank you very much, Dr. Arvind Shenoy, sir, and Dr. Keerthi. Wonderful presentation. and we will join again with another platform. Thank you and goodbye Zoom. We will catch up in Microsoft Teams in the upcoming webinars. It would have been nice if it was followed with a nice dinner. Anyway, good. Chalo, have a great evening. Bye. Take care. Bye.
Thank you. Thank you.